reverse your sitting.
Sitting at my terrace.
Oh yeah, yeah. But if you can reverse,
Okay. You want me to reverse? Okay.
Yeah.
so that
Turn the other side, 180 degree.
then your face will not look dark.
Okay. Okay. I'll
Okay, sir. I'm giving a countdown. 3, 2, 1. We are live now.
Okay. So we welcome all the faculty and all the delegates for HTO subcommittee or knee preservation, knee and hip preservation committee program of HTO pre-basic. We have a stalwarts of HTO here, all the faculty. Dr. Dinesh Bhai is moderating, and Dr. Dinesh Bhai will give the introduction of each faculty, and then we'll start ball rolling with our president, sir, Dr. B. Shivashankar. Dr. Dinesh, over to you now.
You are muted, Dinesh.
Unmute yourself, Dinesh.
Good morning, everybody. Now you can listen now.
Yeah.
So first, I will thanks to IOA for allowing me to organize this program of knee preservation, and I will introduce the first speaker. He does not need any introduction. Is Dr. Shivashankar. He is the president of our Indian Orthopaedic Association at present, and he is encouraging all these academic activities. So it became easy for me to organize all these activities. Now another is Dr. Smarajit Patnaik. He will introduce us about the role of orthobiologics in knee preservation. And after that, Dr. Ravi Mittal, he is from Delhi AIMS, and he will enlighten us with a review of literature on long-term follow-up. And after that, Dr. Sanjai Rastogi, who has a passion to have knee preservation surgeries, and particularly he will introduce us or inform in detail about when to do high tibial osteotomy, when to do UK, and when to do total knee replacement. And again, Dr. Mangal Parihar, everybody knows him. He also does not require any introduction. He is a master of deformity correction, and in osteoarthritis knee, the commonest reason is malalignment. So he will enlighten us where the deformity is and how to tackle this deformity by his excellent presentation. We have even attended so many lectures of him, and he's excellent orator, excellent speaker. We all know him. And after that, I will mention the indications of high tibial osteotomy. I am Dr. Dinesh Thakkar, and practicing at Ahmedabad as a knee preserving surgeon. And after this, Dr. Milind Chaudhary from Akola. He has also a lot of interest in high tibial osteotomy, and he has organized one national conference in 2011 with Dr. Koshino from Japan, and it was an excellent program, and he is doing regular high tibial osteotomy. So after that, he will speak on high tibial osteotomy in large deformity instead of total knee replacement, and after that there will be a question and answer session. So I think I invite our president, Dr. Shivashankar, to start on overview of knee preservation. Thank you, sir.
Good morning, everybody. Thank you, Dr. Dinesh. I must congratulate you and the subcommittee for doing a wonderful job. This is something which is very close to my heart. That is one of the reasons why I thought of having a subcommittee in academic under the banner of IOA, hip and knee preservations. Friends, what I'm talking to you will be probably it's an overview of all the speakers, what they will be talking. I'll be probably showing one or two cases from each one of them, and I put them together in my journey for the last 3 decades with HTO. This is something which we commonly see, a varus knee with the medial joint space reduced, and this is a very ideal case for doing HTO. And we have at the end why HTO is not as famous as knee replacement. A good discussion is going to be at the end. How to select the case? We have to take the single leg weight bearing x-rays. Earlier, I used to use 3 cassettes overlapping, and I had to stitch, spending a lot of time. but with the availability of digital X-ray and vertical bucky, we in quick succession take hip, knee, and ankle X-ray without the patient moving, and the uh, machine or the computer stitches the X-ray for you. I don't like the grid or the lines on the X-ray. That's why I usually put a coin and I take an X-ray like this. And knee arthroscopy is a part and parcel of the HTO because you have to confirm that the lateral compartment is good before you can think of this. Coming to the varieties of surgeries or the options available, earlier we were doing lateral closed wedge osteotomy. Then we started doing partly open, partly closed. Then we started with the Elizro available dome osteotomy. Then what is most in the recent past, we have been doing the open wedge osteotomy. Very recently, we have also started the tibial condyle valgus osteotomy. We have both intra-articular and extra-articular corrections possible. A few cases about HTO with plaster or the Coventry staple. This is one of the case where I have removed a wedge of the bone and I have applied a plaster in the corrected position to get a reasonably good outcome in this lady. Another X-ray, a doctor himself at the age of 65, I operated with a lateral closed wedge osteotomy fixed with a staple, and he also had a very good knee for the next 15 years. Coventry staple is useful. Another case where I have used the Coventry staple and fixed the, because the duration in plaster becomes less if you have used the Coventry staple. Then I started doing partly closed, partly open osteotomy to prevent taking out a lot of bone, because if I had to do only lateral closed wedge osteotomy, a lot of bone required to be removed. So I started doing partly closed. This part will be closed and the osteotomy is extended over the fulcrum here. The medial part gets opened up. So this was very useful, especially if the deformity was little more. This is one example where I have used the partly open and partly closed osteotomy sometime in 2006. Then with the availability of the Elizro, we started doing the barrel dome type of osteotomy, and this one malunited medial condylar fracture treated with this barrel dome type of osteotomy. Then probably after 2005 onwards, medial to prevent the fibula osteotomy, medial open wedge osteotomy became more famous, and with the availability of the Pudu plate, the life of the orthopedic surgeon become very and this is a graft used, and also Pudu plate has been used, and this is the clinical picture of the same patient. So you can see nice correction with these plates available. This is another case where I had done a Pudu plate sometime in 2011, and this patient, this is pre-treatment on the left side and post-treatment on the right side. You can see a good correction. He had in 2019 intertrochanteric fracture. That time I had the opportunity to take his X-ray. After 8 years, he was still having a good correction, and he was happy with the result he could get. Then with the availability of locking plates, the tomofix became much more calmer, and the necessity to put a graft was not there, though we were not very sure of not without graft using the tomofix, but nowadays we use without any graft, and this is one such case where tomofix was used. At present, my majority of the cases I treat with fixator-assisted medial open wedge osteotomy. This is my personal preference, though tomofix is equally good. But one of the reason is fixator can be repeatedly used, and it pays back because the cost is also very important. Tomofix plate itself costs, even the Indian version costs about 20,000 rupees. So that is one of the reason why I tend to use. And another reason is this fixator is a Atmanirbhar orthopedics. This is my own theme for this year. This fixator has been designed by one of the speaker today here, Dr. Mangal Parihar. So it's a Indian implant and the Indian fixator, which I'm very happy, and I have been using this. The advantage of the fixator assisted HTO is there is no osteotomy required. There is no wedge of the bone required to be removed. There is no fibula osteotomy required. There is no plaster to be put. Most important, if you use a tomofix, you have to remove the implant. or if you don't remove with these locking plates, if the patient requires in future TKR, that becomes a very problem. So that problem is not there with the fixator. This is a mother of a doctor with a early medial joint space reduction and early osteoarthritis, where I have used the fixator, and this is on table correction to confirm that the correction is possible with this amount of wedge removed, osteotomy done. And Dr. Mangal Parihar will be talking more about this. So these are some of the and you can see that patient is walking comfortably with the fixator, and this is the end of the surgery. At 3 months, you can see nice consolidation. And if you see the weight bearing axis, which was passing medial to the knee joint, you can see it is passing through the center. What we aim is the Fujisawa point at the lateral tibial spine. Another young lady, 33 years young lady, already cartilage mapping was done, and she was already advised TKR at the age of 35 years. She came to me. I offered HTO. These are the weight bearing x-rays in that patient. I did little over correction because the varus was not much, but pain was more. So I thought to offload the medial condyle, which had some subchondral cyst initially. So this is at the end of the treatment. He had a very pain-free knee after this because of the offloading of the medial joint space. Another elderly lady, the left knee was severe than the right. You can see the branding scars as well as the Moran-Baker cyst on the left side. And this patient also I have treated with a fixator to get a good result. You can see the pre-treatment and the post-treatment X-rays and the mechanical axis. A bad deformity due to malunited fracture. Again, this patient, I'm intentionally showing this because I had a lot of problem because you can see that the deformity was more and my fixator was unable to correct because even after changing the threaded rod, I was unable to correct. Then I contacted Dr. Mangal Parihar. Then he said, the way I have put the pin, it is wrong. I should have put the pin parallel to the osteotomy. This fixator would have worked better. So this is that's the reason why I always say you can get the facts from the Google, but you can get the Gnan only from my guru. So this Gnan I got from my guru, Mangal Parihar. And in this patient, I had to change the rod and also finally I got a good outcome in this patient. So when I did the next case, this is the clinical picture, pre-treatment and the post-treatment. When I did a next case, again, a badly comminuted bicondylar fracture. I remembered this, again, a very bad varus in the knee joint. You can see now that I have put the shank pins parallel to the osteotomy site. There was no problem with this 10 millimeter distractor, which could correct the knee. The picture you can see on the right, correction, and the patient is comfortable with the while walking. These are the clinical picture pre and post surgery at the end of the treatment. Another interesting case, bilateral varus knee. This patient I had seen in 2013. Left side was more severe, painful, so I did the surgery on the left side. He came back to me only in 2019 with good correction on the left side, but you can see the right knee. This is very bad now. So I advised at this time, not an HTO, but a TKR. So this is the picture at the time before the TKR. This TKR was done on the right side. And these are the clinical picture after the TKR. And this picture she sent me during the lockdown, which shows HTO on the left side and the TKR has been done on the right side. These have been sent by the patient by WhatsApp. What is new or the latest? Intra-articular HTO or TCVO or tibial condyle valgus osteotomy. Dr. Suka Tsukasa Keramoto from Japan has introduced this technique where intra-articular osteotomy is done and the correction is done. So this is the pagoda type of tibial upper plateau, which is split vertically and it is corrected. Dr. Milind Joshi will be talking more. Milind Chaudhary will be talking more about this. This is his own case where you can see the weight-bearing axis, the intra-articular osteotomy and fixation with the tomofix. Another case from my friend, Dr. Samir Shah from Baroda. Again, he has used the same technique, intra-articular osteotomy, vertical osteotomy, and a medial opening wedge osteotomy, then fixation with the plate after the correction of the deformity. So you can correct the deformity and fix this with a tomofix. So good correction is possible, and whatever is required can be done on the table with this technique to get predictable outcome. This is what is something which is new now, which has been done by many of us in the last 5 to 10 years of time. Once this was introduced to us actually by Dr. Milind Chaudhary in India. So this is the function at the end of 1 year. Lastly, intraarticular and extraarticular, if the deformity is bad, like this, again, Dr. Milind Chaudhary will be talking at the end of the last talk in this today. So where he has used both intraarticular and extraarticular correction to get the predictable outcome in this case. Even partial replacement is a type of knee preserving surgery, unless you are doing a total hip replacement. That's good. This is the last case I am showing. An interesting case. I had done HTO on the right side in 1997. She underwent TKR in 2015 after 18 years. And unfortunately, she had a lot of complications on the right side. She had a fracture in the tibia, which went into non-union. We had to operate and get the union. It almost took 3 years for me. Then only in 2019, I did the TKR on the left side. So this is on the right side and the left side. Right side was where HT was done earlier, then TKR was done. So you can see multiple surgeries has been done on the right side with the peri-implant fracture. So then only after getting that union only, I did the TKR, though she was ready for TKR on the left side. Friends, if you see a patient like this, try to save the knee, look for alignment, consider early osteotomy, definitely delay the knee to a future age for a probably correct age for TKR. HTO is a predictable outcome is possible. Accurate planning is required. The technique is accurate. You can get whatever you want to get. Pre-plan, whatever the planning you have done, you can get it on table. Try to solve the OA knee problems by knee preserving surgeries before considering knee TKR. Knee TKR is also good, especially if the knee is totally gone. But if the patient comes to you early, it's always better to save the knee. Thank you very much.
Thank you, Dr. Shivashankar, for explaining everything about different methods of tibial osteotomy. And now I invite Dr. Smarajit Patnaik, who will talk about the role of orthobiologics in knee preservation. Welcome, Dr. Smarajit.
Before he starts, there is one question.
Sure.
We have arthroscopies here also. Dr. Shivashankar, do you do all the patients arthroscopy preoperatively to check the lateral compartment? That is the question.
Earlier I was doing, but nowadays I know that there is nothing much. Which, if you have got a good X-rays, weight-bearing X-rays done, and the patient is young, anyway I'm going to do the knee preserving surgery. So nowadays I tend to bypass that. But yes, I have been doing earlier.
What is the opinion of other faculty and Roshan Wade?
Hello.
Dr. Roshan? Yeah.
Yeah. Can I speak?
Yeah, yeah.
Yes, yes, Roshan.
I think there is a concrete role for arthroscopy in HTO surgery. Although Sir has changed his practice, the science has not changed.
Yeah.
There are n number of articles and publication and personal experience, as well as the evidence and eminence-based evidences to prove the fact that arthroscopy has got better role in combining whenever you do want to combine it with HTO, because I think one has to consider knee as an organ and treat it as an in toto rather than just treating the malalignment. We have to take care of cartilage, the meniscus, and the torn ligament. And those situations, I think the role of arthroscopy is very important, because what you are seeing on MRI just sometimes it's very difficult to pick up the cartilage lesion as well as the meniscus lesion on MRI. So in those situations, if you do an arthroscopy, you'll get a better understanding of whatever damage has happened, internal derangement of the knee has happened, and one can treat it accordingly. So I think that's a very biological way of going ahead with the surgery. So in my opinion, arthroscopy has a good role in combined HTOs.
Okay. What other faculties have? Dr. Mangal?
No role.
No role.
As a
Okay.
preoperative assessment, it has no role unless the patient has specific intraarticular symptoms of locking or something like that. But otherwise, an MRI can assess the lateral cartilage. If you look at all the long-term papers which have looked at the long-term results, most of them have been done without arthroscopy. So arthroscopy is not supported by evidence. You'll find a lot of papers which say that we do HTO and we do an arthroscopy before that. But that is not evidence. Evidence is if you do 100 patients with arthroscopy and 100 patients without arthroscopy before HTO and show that the patients who underwent arthroscopy last longer or have a better result. So right now we are in the area of eminence-based medicine, where, for example, I think that it's not needed. Roshan thinks that it is needed. So it comes down to what each person is, convinced about. We've done a lot without doing an arthroscopy, and we've not had trouble. My take is, if at all there is an intra-articular issue, and because of the HTOs, problems don't settle, you can always do the arthroscopy as a second procedure. But in over a few hundreds, I've not had occasion really to do it post HTO.
Now there is a follow-up question also, that doing arthroscopy and then doing HTO at the same stage, is there any problems because of the doing arthroscopy and
I
leakage
think
and all?
that question comes from the earlier way of doing an osteotomy, where they used to say that never combine an open surgery with an HTO, because in those days the HTO used to be immobilized.
Yes.
So that could possibly, and then you had the patella coming down, etc. So that could lead to stiffness. But today, with modern techniques of fixation and arthroscopy being a relatively non-invasive procedure, patients get going on their knee movements pretty quickly. So in that sense, I don't think there is any objection to arthroscopy.
Okay. Anybody has any value addition, then we can go ahead with the role of orthobiologics.
The only thing I would say is arthroscopy is contraindicated in osteoarthritis knee because it leads to deterioration of the knee faster, and that's from American Academy. So
You mean before osteotomy? I don't agree with that. That's
no. I'm not saying before. They say arthroscopy has
Only
no role.
Okay, only
in
arthroscopy has no
osteoarthritis
role.
knee.
Yes.
Number two, if there is a mechanical problem, the way you said, only then it should be done. Number three, if you do a arthroscopy knee joint, it will lead to early deterioration of the knee just by arthroscopy. So it is not indicated.
It's difficult to take it on the face value.
This is from academy.
Arthroscopy. Yeah, only arthroscopy is not having.
That's what I'm saying.
It's just cleaning the house procedure. That's all. But
yes, that's what I was saying. That is actually what the academy is saying. What I think
arthroscopy and washing the joints reduces the inflammation to some extent. It has some role. But anyway, as Mangal said,
on a short-term basis.
Yeah.
But not on a long-term basis.
Okay, sir. Sure.
May I add something?
Yeah, you can, sir. Please.
See, arthroscopy is not mandatory for HTO. There are many people who don't do arthroscopy, but there are a big number of people who combine arthroscopy with HTO. What advantage does the arthroscopy give is that you can debride the loose cartilage, you can do microfracture or chondroplasty just to enhance the regeneration of fibrocartilage over the condyles. So the evidence is, the new evidence which is coming up, that you can have better pain scores, you can have better function if you combine arthroscopy with HTO. The evidence is both ways because there are two group of people who are doing arthroscopy with HTO with arthroscopy or without arthroscopy.
Right.
Can I make a comment on that, Ravi? At the risk of sounding a little facile,
Yes, sir.
अगर हम HTO करने के बाद थोड़ा गंगा जल भी छिड़का दें, then you can say that the result is better. That's what I'm saying. That really speaking, as yet I don't object to it, but there is no evidence which shows that doing a microfracture improves results. Loose cartilage flakes, etc., improves results. There is no evidence, really speaking, which shows that. Yes, one could argue that unless you do arthroscopy and compare, how will you come to know? That's a fair judgment. So that's why I don't object to arthroscopy, but at the moment there is no evidence which is in favor of it. That's my point.
When we are living in an era of evidence-based medicine, we don't have randomized control trial to prove this way or that way. But the bottom line is adding a arthroscopy, doing a microfracture doesn't deteriorate the result. It can only add to it, but not give negative effect.
In a private practice setting, it adds to the cost. Definitely.
Sir, मैं तो सरकारी में हूँ.
Exactly.
Right.
रोशन को पूछो कितना पैसा लेता है वो.
I think we are deviating for the academics.
Academics, yeah.
Yeah, I think Smarajit, you can go ahead. Yes.
Before we wind up this combining arthroscopy with tibial osteotomy, when we have an opportunity to remove the implant of a tibial osteotomy, so at that point of time, there is probably some role of an arthroscopy to see a lot of things, whether even if it's not a protocol, but it's the way the science can progress and has progressed is when in cases like root tears of the meniscus and where we have done tibial osteotomies and changed the mechanical alignment, and we have seen a lot of regeneration even in these meniscus and the cartilage tissues. So probably while we have an opportunity to remove the implant in a case of a tibial osteotomy, probably adding on an arthroscope at that point of time can give us something about to know exactly for what we have operated and how much it has given us a sort of a improvement in those type of pathologies which are not necessarily only related to mechanical alignment.
Yeah. For that, you have to pre-operatively also do. Then only you can compare whether it has healed or not. So,
Yes.
only doing post-operatively is not having any value then.
Sir, a quick comment on evidence, because I think today when we talk, we always talk about evidence and what are the current evidences. Whether we agree to disagree, but there are n number of literature, including the paper from Dr. Bode, Dr. Parker, the Sterrett, and the famous surgeon Dr. Rob Laprat, where they have shown almost a 15-year comparative data, where the arthroscopic procedure in the form of the microfracture, also in the form of the autologous meniscus transplantation, also in the form of meniscus repair and root repair, has shown a wonderful result as compared to a non-arthroscopic group. And this is in public domain. I'm not talking from my own act. And there is a ISACOS guidelines. I'm not talking again evidence-based, eminence-based medicine. Here I'm talking about ISACOS guidelines, where they say that pre-operatively arthroscopy before doing HTO at the same sitting has a better advantage in the HTO surgery as compared to not doing arthroscopy in younger arthritic individuals.
Okay. Dr. Rosenwade, you have a very good background voice of Kawas. The terrace.
I'm saying in nature.
Okay. Fine. Dr. Samar.
Yes, sir. Thank you. Thank you for Indian Orthopaedic Association for giving me this opportunity to be a member of the Hip and Knee Preservation Subcommittee and give me this opportunity to talk something about the orthobiologics in knee preservation. Now, what are these orthobiologics? These are defined as per the AAOS. These are biological substances which are found naturally in our body, and this help in healing of the injuries and obviously more quickly. So what are the different types of these substances which we have? Henceforth, as we keep on the presentation, we will talk viscosupplementation as HA, hyaluronic acids, the platelet-rich plasmas as the PRPs, the autologous conditioned plasmas as ACS, and the stem cells, they are the bone marrow aspirate concentrates as BMSC, and the adipose-derived stromal cells therapy as the ASC in the treatment of osteoarthritis. So these viscous supplementations, this consists of the hyaluronic acid treatment, which is injected into the joint for relief of pain, and possibly also has got an anti-inflammatory effect. Now, this HA is found normally in the joints, which provides, as we all know, the viscoelastic properties of the synovial fluids. Now, before we argue on what role it has, it is more of a consensus that when not at all to use viscosupplementations, and these are when there is a symptomatic athlete who has mechanical meniscus pathology with underlying osteoarthritis of the knee, when we have symptomatic athletes with osteoarthritis of knee which have active inflammatory arthritis, and similarly, symptomatic athletes with OA of the knees who have synovitis of the knee with significant effusion. So these are the conditions where definitely a big no to the viscosupplementations. So what are the spectrum of these injectable orthobiologics? There are some acellular parts which are derived from the blood. The cellular part, the stem cells, which we have still to have a lot of things to be done on those things, the BMSCs and the adipose-derived products, and the future is the gene therapy. There are techniques of in vivo and the ex vivo techniques. And a brief note about the platelet-rich plasma. As we all know, the cartilage is non-vascular. It gets its nourishment from diffusion. So if we have this high concentration of intraarticular injections, they are often preferred and seen to be at least an experimental level and clinical studies level for helping in cartilage regeneration. Now, what these platelet-rich plasmas provide is that it provides the growth hormones, it provides a system for recruitment of the cells, it helps the cellular migration, it helps for growth of the cells and some amount of morphogenesis, and also it reduces some amount of inflammation. So overall, the body of literature suggests PRP is having a promising role for symptomatic relief and improved functional outcomes in patients with osteoarthritis for at least a period of 1 year. That's very important. Now, these low molecular weight, hyaluronic acids have been shown in combination with the platelet-rich plasmas to be slightly more effective. And there is a school of thought where the combination of intraosseous and intra-articular platelet-rich plasma injections in more advanced grades of osteoarthritis not only targets at the articular surface and the synovium, but also the involved subchondral bone, and has shown some initial results of improved pain and function even in KL3 and 4 categories. A brief about the process of this, how do we derive this, get this the platelet-rich plasmas. There are a lot of techniques, but I'll try to keep it simple. The basic one, the simplest one, is we have a centrifugation process, take about 10 to 15 ml of autologous blood from the veins, and we centrifuge about 3,500 to 4,000 RPM for about 12 to 15 minutes. And after centrifugation, you have this, in the lower part, you see the RBCs. Now above that is an inner jet layer, and above that there is a buffy coat layer. And on the top is the platelet poor plasma. And once we remove the topmost 2 to 3 ml of platelet poor plasma, then we have the platelet rich plasma. So this is how it looks after we remove the platelet poor plasma from the top. Now we can do it without ultrasound guidance, but evidence and the ultrasound guidance give us some advantage. Now here the ultrasound shows the suprapatellar recess, how it is seen. Now in this picture, we see the needle is entering, just as you see the white straight line here. This is where the needle is entering, and the needle is now, this is the entire needle now in the suprapatellar recess. And this is just to recapitulate the same picture about the different layers. And under the guidance, the PRP is injected, and this white structure is the needle, and this is the platelet, this is the recess. Before instilling the platelet-rich plasma, it is very important to aspirate the synovial fluid. So this is how about we give the platelet-rich plasmas. A bit of slide about the discussion part, where the guidelines for hyaluronic acid treatment have been less than enthusiastic. We all know that it's not much supported by the AAOS also. However, much of the data shows it to be safe and efficacious in patients with osteoarthritis compared with platelet-rich plasmas and other things which are coming. And multiple meta-analysis of platelet-rich plasma suggests that it's a promising therapy for symptomatic relief of pain, at least for 12 months and after. Now, autologous chondrocyte therapy serum therapy have been less conclusive than the use of the platelet-rich plasmas, whereas the cell therapies like the bone marrow aspirates and the adipocyte aspirates, these are at the forefront of the tissue engineering, and there are a lot of potential benefits in these. And these therapies are stem cell treatments, which has to be further understood and the treatment protocols laid down. So with more such studies, cell-based therapy may have the promise to be used in osteoarthritis. Well, this slide is a beautiful algorithm, but unfortunately, because of lack of level 1 evidence, we cannot suggest that it can be used at this point of time. When we have this algorithm, whether if there is somebody has a systemic disease or a poor healing, then we have to consider like the bioidentical hormone levels and the microbiome evaluation of the synovial fluid. And when there is no systemic disease or there is no history of any poor healing, and the KL grade of osteoarthritis is 3 or 4, then we can try on the bone marrow aspirates when we can give the matrix, or we need not. And when we have subcortical changes or cell depletion, then also we have a role of the bone marrow concentrates. And when this nothing is there, all this, there is no systemic disease, the grade is less, there's not much of subcortical changes, then we can go for the leukocyte poor platelet rich plasma, and we can add matrix to that also. And when we at 6 to 12 weeks, we evaluate for the pain and the function and check out for the mobility and stability. And if there is less than 60% improvement, then we have to consider retreatment or higher order of the graft, or change the algorithm. If we have a reasonable amount of success, then we can follow that every 3 to 6 months. A look into the future, the gene therapy, it targets at long-term therapy. All these techniques, other techniques which we are discussing, it requires multiple sort of frequency we have to give them. Whereas the gene therapy, it is a long-term therapeutic agent, and it's rebuilt to damage, it helps in rebuilding the damaged articular cartilage, especially in early stages of osteoarthritis, where we still have a lot of normal cartilage tissues. So the strategy here is we use gene transfer techniques, and these are inserted into the inflamed knee, which suppresses the inflammatory factors, and also it overexpresses the therapeutic factors, the various growth factors. So this gene delivery can be done through viral or non-viral vectors, and there are different techniques of in vivo or ex vivo approach, where we try to give the various growth factors, and also we try to give interleukin 1 RA, which is a restrictive. Once we restrict this particular this one, the ligand, so this definitely helps in reducing the inflammation in the knee joint. So orthobiologics are same and seem to support their use in the treatment of osteoarthritis for up to about 2 years. So these treatments are easy to obtain and relatively inexpensive. And orthobiologics may yield superior results in the treatment of osteoarthritis relative to more conventional approaches because of their ability to target repair and regeneration and dampen the inflammation. So future work should be targeting the factors that are more beneficial and effective in treating osteoarthritis, and we have to determine the dosages, the timings, and in addition to administration methods also, and develop proper algorithms. So thank you for your attention.
Thank you, Dr. Smarajit.
Thank you, sir.
Now, I think, is there any question, or we should go ahead?
Inter-faculty, if there are any questions, any faculty has a question or any value addition, then we can add on.
I think any others have
Yeah.
tried this
Orthobiologics.
hyaluronic. Yeah, I have used in some, but at very early stage, it helped in some patients. But as Dr. Smarajit has said, in a little bit at more osteoarthritis, it poorly works, I think.
Yes, Roshan.
Yeah, if you allow me to comment on this PRP, we have been using this, but a role of PRP, especially in, as a remodeling agent for the articular cartilage, has not been well defined. In fact, if you see the guidelines, even the US FDA laws and things, they don't allow the judicial use or as a standard operating practices in the medicine to be used for the articular cartilage regrowth. Here, the one has to understand that this disease is not only the arthritis because of metalloproteases and enzymes which are produced, and it's very difficult to nullify those enzymes when you want to address the issue of arthritis. And one has to understand is a beyond biomechanical disease. It is the degenerative process which sets in, and it's very difficult to reverse those by just adding PRP. So as Mangal said, if you after H2O, even if you put a Ganga Jal, it will work, and that is what happens. So so the evidence whether it works or doesn't work, again there is no evidence, no eminence. Apart from the studies which are anecdotal studies and individual studies at and as few expert center with probably a bias, the professional bias attitude, these studies has been published, but there is no control randomized prospective data to show that it works irrespective of your mechanical alignment correction.
Smarajit, I have got a question. Do you give knee lavage before you inject this PRP or just you inject this PRP?
Yeah, that's very important. Like when we have a synovitis stage, or even when we have a lot of fluid, synovial fluid in the, that's the advantage of doing it under ultrasound guidance. So once we see that there is a lot of synovial fluid, these are the quality of this synovial fluid is obviously not what it's in a non-osteoarthritic knee. So we should aspirate these fluid before we inject the platelet-rich plasma. That's very important and fundamental.
Okay, you are just only aspirating, or also you are giving a cold saline lavage or a saline lavage?
No, only aspirating and then locally instilling these PRPs.
Okay.
In fact,
As we, it has to be basically seen as a modality for pain management rather than trying to be a restorative, regenerative medicine, which is unfortunately a lot of
I think he has network issues.
Hmm.
Yes, Roshan, you are adding something.
yes, sir. I was trying to say that number of like PRP is on enzymes, and secondly, the number of stem cells. If you study the number of stem cells per cubic mm, the highest source of stem cell.
So it's basically it is coming to preventing early osteoarthritis in athletes. It has got some role. When it comes to managing the pain in case of young arthritis, it has up to a period of 1 year and beyond. It has got some role, and beyond that, it has got very limited scope in the present day practice.
Hello.
Yes.
Yeah. If I can add the number of stem cells and mesenchymal stem cells in the body, synovium comes before blood. So if and the cartilage comes second, then you have fat, and then you have the bone marrow. So the mesenchymal stem cell strength of synovium itself is very high as regards to the cartilage. So again, I didn't get the idea why you have to inject PRP, where already there is a higher number of stem cells which are preserved inside the knee joint. and it can work in the better benefit. Dr. Samarjit, if I can get a scientific evaluation of those studies, the number of stem cells in the bone, the platelet-rich plasma vis-a-vis the synovium.
Okay. I think it's basically the non-cellular part, which is we are focusing here by giving a PRPs, where apart from the cellular aggregation and proliferation, the humoral factors in terms of the growth factors, the platelet-derived growth factors, and the other group of growth factors, which has got definite role in reducing the pro-inflammatory markers, and probably that is where they reduce the pain. And that is where it has got more role rather than more into the regenerative part, as we think, because as you told, the mesenchymal cell concentration in other things are much more compared to the PRP. So they don't have much of role in regeneration of the articular cartilage, rather more in the pain management and the control of the pro-inflammatory markers and interleukin, and reducing the inflammation of the joint.
But there is a question on the clinical grounds that how many days it relieves the pain. If it is on the pain management, how many days? It varies person to person and varies patient to patient. That is the perception by audience.
Absolutely. And that is what the science has to also grow and to tell us, to develop algorithms, how frequently, what dose, which way we should give these injections. So all that is still in an experimental stage, although there are some early sort of evidences which can show that it is effective in pain management. But the watershed line between the PRPs and the hyaluronic acid is 12 months, where we see increasingly patients getting pain relief even up to 12 months. And it is again the European Academy, once the American Academy and and the Canadian Academy, they are not much in favor of these hyaluronic acid injection into the joints. The European Academy suggests that if your patient, index patient, has got some relief even from the hyaluronic acid injection, you have still a role of injecting that maybe in another 6 weeks to 3 months time, where you expect some more of pain relief from these type of patients who have already got benefit from these things, these injections into the joint.
There is a question from YouTube. Dr. Mozimil Siddiqui wants to know what is the advantage of double spin PRP over single spin PRP, and he also wants to know how to perform double spin and get the double spin PRP. So technical aspects also he wants to.
Technical aspects, yeah. There are two types, like I was telling, the leukocyte-rich ones and the leukocyte-poor ones. So leukocyte-poor ones are, leukocyte has got some additional effect role when we use them along with the PRPs. And at the same time, it has got also some negative role in terms of these inflammatory markers. So when we use this double spin ones, they are the ones where we get the leukocyte poor ones. The WBCs are not there much. So that is the most preferred way, where it's a low spin one, and the spin is done for lesser time. So 5 to 6 minutes. So there we get the leukocyte poor ones. And these leukocyte poor ones have got some advantages in terms of clinical scenario, in terms of pain relief. Whereas the leukocyte-rich ones, they are seen to be more effective at a longer point of time in terms of, that means giving relief of pain for a more longer period of time. So once we consider the leukocyte-rich ones, they have to be double spin and for a longer duration of spinning has to be done there. So all this is definitely at a much premature and an experimental level. And that's where the science has to grow into the knee preservation, trying to preserve literally in the preservation sense, without and it should be attempted at a very early stage of the knee osteoarthritis.
Dr. Samar, how many injections you give? 1 injection, 2 injection, 3 injection, or it is?
Yeah, 3 injections. 3 injections.
3 injections.
Yeah.
Milind Chaudhary has joined. He has got a question. Yes, Milind. You have to unmute. You have to unmute.
Yes, I hope you can hear. Good morning, everyone.
Yeah, yes, good morning.
I was at several conferences in Europe some time back, and there's somebody who had read a paper with 3,000, so I wanted to talk to him. And so before I asked him a personal question, he went up on the podium and said, I have given 3,000 orthobiologic injections in the knee joint for osteoarthritis over the last 10 years. And now I can tell you that it doesn't work. So my friend, Professor Smarajit, I apologize, but I heard this. And I've done platelet for non-unions, bone marrow aspirate concentrates. I started this work 10 years back. I was tempted, but I've never done it because I heard this. It's better to offer people more reliable. I think gait analysis and exercises in the early stages would help far more. But I agree, there may be a future, just like BMP's work. There may be a future in which we have more isolation of factors, a better understanding. I do agree, it's a work in progress.
Absolutely. It's a work in progress. That's the way we should look at it at this point of time.
Milind, did you give 10,000 PRPs?
I've not given a single one. I dare not.
So your comment is null and void.
Okay.
We accept only
Sure.
your comments.
But we learn from the mistakes of others.
Okay, I think we can proceed. Dinesh.
Yeah, now I invite Dr. Ravi Mittal for the next talk of review of literature on long-term follow-up.
Sir, there is a question from YouTube. I'm sent in the chat box, sir.
Yeah, that has been taken already.
Oh, sure, thank you, sir.
Can you see my screen?
Yeah.
So thank you very much to the organizers for inviting me. So my aim would be to review the literature on the outcomes of the HTO and convince the audience to have a kind look for this procedure and also dispel some of the controversies and myths surrounding this procedure. So when we look at the data in the literature, there is a lot of heterogeneity in it. And people have used different definitions for survival of the procedure or the failure of the procedure. Some have used conversion to knee replacement as the endpoint. Some have used a predefined or predetermined functional score. And when the functional score falls below that level, it's a failure. Some people have used radiological destruction without conversion to TKR as the endpoint. Some people have used re-osteotomy as the failure of the index procedure. And all these endpoints have been used with and without Kaplan-Meier analysis. So there's a lot of difference and heterogeneity in the data. People have different duration of follow-ups, and it ranges between 5 and 20 years. So that's a big variation. People have used different functional scores, pain scores, and pain satisfaction scores in their studies. Somebody has used functional score alone. Some people have used 2 of the 3 scores. Some people have used 3. So it is very difficult to match different studies and have a good meta-analysis. And obviously there is a difference in the surgical techniques of different surgeons. Then what is a good alignment of the knee? People have used hip knee angle. Others have used the point where the mechanical axis passes, either to the Fujisawa point, or some people have even used the middle of the lateral condyle, lateral tibial condyle, where the mechanical axis passes. Then identification of the risk factor is not uniform. People have used as old age, high degree of virus, female gender, high BMI, and high degree of osteoarthritis to begin with, and undercorrection as different risk factors for failures. But the commonality among all the studies is undercorrection. So that means the surgery has to perform very accurately to achieve a good mechanical alignment, to achieve a good result. Now, when you look at the data, if you have a single study, people give you a single figure like 90-degree survival at 5 years, 87 at 10 years. So there's a single figure. But when you have a meta-analysis, the study gives you a range. The survival is from say 70 to 90% at 5 years. So you have a minimum value and a maximum value. When you look at the maximum value, it's very encouraging for the reader that this procedure is good. But when you look at the minimum value, some people might be disheartened to read that minimum value. And all these meta-analysis also give a single figure, which is the average. Now, average is not adding the minimum and maximum dividing by 2. It's by a different method. So let's look at this chart. This gives a survivorship of HTO from year 1999 till 2008. This is a study in 2004 by Cochino. The survival is 97.3 at 7, 95 at 10 years, and 86.9 at 15 years. 2008 survival is 97.6 at 10 years, 90.4 at 15 years. A little less good is 94 at 5 years, 79.9 at 10 years, 65.5 at 15 years. And if you look at this figure, this is not as encouraging as the study by Cochino. It is just 65 to 74% at 10 years. But just don't look at the face value of the figure like 65 to 74% at 10 years. But you can interpret it this way, that you have avoided TKR in 65 to 74% of people to avoid a TKR for 10 years of their life. Now that's a very big figure. They have unrestricted activities. They can do everything for 10 years of their life. Now let's look at some recent evidence. This is in 2018. The survival of medial opening wedge HTO is 95% at 12 years of the procedure. This study in 2019, the survival rate was 99.1 plus minus 0.4% at 5 years, 94 at 10 years, 84.6 at 15 years. Quite encouraging. In 2020, the 15-year survival was 92.5%. Year 2021, they found that the patients with the HTO showed a very good results, and the health-related quality of life was nearly as high as in general population. Now, this is never achieved by any knee replacement. The patient always has some issues with his knee, and he doesn't feel that this is natural. So with the HTO, you have the patient feeling a natural knee, and the health-related quality is as good as in general population. Now, if you look at this chart, it talks about different studies, and they are ranging from year 2000 till 2018, and we have survival in 10 years, 12 years, 14 years, 15 years, and 18 years. So all these studies, they give a single year survival, except the second study in 2017, which has endpoints at 2 points. That means 12 years and 14 years. If you have a 10-year survival, it ranges from 72 to 87. If you look at 12-year survival, it is ranging from 86.4 to 95%. The 14-year survival is 82.8. The 15-year survival is around 87%, and 17-year survival is 94%. Now, if you look at this chart, it looks very funny that the 17-year survival is 94% and a 10-year survival is just 72%. So the answer is that you are looking at different studies. So when you look at the data, you have to be very careful what you're looking at. Now, this is a recent study in 2020. This was a review of HTO, and they say that the 5-year survival is 86 to 100%. 10-year survival is 64 to 97.6%. The 15-year survival is 44 to 93.2%, and 20-year survival is 46 to 85.1%. Now, if you look at the maximum figures, they are very, very encouraging. They are as good as joint replacement. But if you look at the minimum figures, they are not very encouraging. But I think one should ignore, because the average is not adding, say, 46 and 85 and dividing by 2. It is something very different, which will be much nearer than to 85%. And this review found that the subjective scoring system showed an improvement, and it was sustained improvement, which deteriorated very less with time. And they were able to analyze that the need for arthroplasty could be delayed by more than 15 years in maturity of the patient. Now, 15 years is a very, very long period, and it can make a lot of difference to the population. So let's come to different controversies. Which one is better, medial opening wedge or lateral closing wedge? Now, this study in 2014 that says that there is no difference in the two procedures at 6 years follow-up. You can do either of them, it's equally good. So this is the summary of survival of lateral closing wedge osteotomy and medial closing wedge osteotomy. The 5-year survival is almost same, 10 years, okay, similar, but the difference comes in 15 years and 20 years. Now, this would say that the medial opening wedge is bad, but reading between the lines, we have very few studies which have 15-year follow-up in the medial opening wedge, because this is a more recent procedure, and you have very almost none with 20-year follow-up with the medial opening wedge. So when you analyze the data, one should not be carried away. You should read between the lines. The other controversy which is propagated by the advocates of arthroplasty is when you have a bone-on-bone lesion or the kissing lesion in medial compartment, you can't do HTO. But this study in 2017, they studied HTO in 2 groups, with kissing lesion and without kissing lesion in medial compartment, and they found favorable outcome in both the groups, and they inferred that HTO is a good alternative option for degenerative osteoarthritis with kissing lesion in relatively young patients. Now, in this study, which was published from Korea, they did HTO and UKR with kissing lesions in medial compartment osteoarthritis. And what they found out that the outcome of HTO was similar to unicompartment osteoarthritis in these patients with kissing lesions. And so the inference is the HTO is a very good alternative to unicompartment osteoarthritis, and when you have medial OA in relatively young patients. This study in 2013 that it tells about what's the effect of age on HTO. It says that you don't have to consider age when you are deciding about HTO, because the outcome is independent of the patient's age. Year 2017, they had 2 groups of patients, which was one was more than 65, other was less than 65. And they inferred that the age did not influence the outcome, either clinical or radiological, after HTO. Year 2019, again, they had 2 groups of patients, less than 64 and more than 65, and there was no significant difference between the survival rate between the 2 groups. So HTO can be done irrespective of the age of the patient. Controversy 4. Again, this is advocated by propagated by advocates of joint replacement, that you can't do simultaneous bilateral HTO, whereas you can do simultaneous bilateral knee replacement. So this study shows that you can do bilateral HTO when you have a good stable fixation, either by a fixator or by a locking plate. The only thing is, when you do a bilateral HTO, you might have more requirement of blood transfusion. Another controversy is that HTO can cause patellofemoral problem, either patella baja or patella alta. Now, this study, as recent as 2021, it says that when you have patella infra, a slight downward shift of patella in open wedge HTO, it doesn't affect cartilage, it doesn't affect clinical scores of the patellofemoral joint. Now, Another controversy is that HTO is very unpredictable. Some people may have benefit, some people may not have a benefit. Again, this is unfounded. People have said that if you use a temporary unloading brace and the patient improves with that unloading brace, you can be sure that HTO will give a good result. Either it can be open wedge or a closed wedge, any type of fixation, but HTO will give you good benefit. Controversy 7, that HTO is inferior to UKR in long term. Now, this study in 2017, they were unable to conclude which method is superior because both gave equally good results. Study in 2013, it was a meta-analysis. They said that the valgus HTO is more appropriate for younger patients who accept a very slight decrease in their physical activity, but medial UKA was appropriate for the older patients who had reduced physical activity. The results were equally good on both the options. 2016, a systematic review found that with correct patient selection, both the procedures shows equal and effective and reliable results. So you can do anything. It depends what you believe in. Again, this is a previous reference. In this kissing lesion group of patients, HTO was compared to UKR, and they found that the HTO is a good alternative to unicompartment replacement. The additional benefits of HTO is that it improves the gait, it improves the spinal alignment, especially in the coronal plane. It also improves the ipsilateral ankle osteoarthritis if it is present. So to conclude, HTO has acceptable long-term clinical and functional result, and that should not be underestimated by any orthopedic surgeons under pressure to perform arthroplasty procedures. Thank you very much.
Fantastic review of literature.
It's very nice presentation actually.
Thank you.
Is there any question from the audience, sir?
Ravi, your last sentence was very important. Perform under pressure.
Now, this is not my sentence. I have just copied it from the article. That is why I gave a reference in the conclusion also.
Very nice, Professor Mittal. It's really worth
Thank you.
Listening to this very encouraging, very measured exposition.
Now, should we turn on the next speaker, or is there any question?
I don't think there will be any question because such a wonderful talk with so much of literature covered, and yeah, we can proceed further, Dinesh.
Now I invite Dr. Sanjai Rastogi to talk when to do high tibial osteotomy, when to do unicondylar knee replacement, and when to do total knee replacement. Yes, Dr. Rastogi.
At the outset, I'd like to thank the IOA's President, Secretary, and Dr. Dinesh for having organized such a nice series for the benefit of average orthopedic surgeon for a condition which is so very common. The objectives would be that we must understand that the primary osteoarthritis knee is a progressive disease, and we must evaluate patient's right factors for decision making and then decide which is the ideal case for STO, UKR, or TKR. And this point has been already discussed. Arthroscopy has no role in primary osteoarthritis knee except when there is a mechanical issue. Now, as per the Kelvin-Lawrence grading, in the initial stages, there are hardly any changes, but in grade 4, there's an involvement of both the sides of the joint. And if we follow these patients regularly, which the average orthopedics must do, that follow with the passion like a diabetologist will follow a patient of diabetes. In grade 1, we must emphasize about lifestyle modification, weight control, and exercise, which must continue through lifelong. Grade 2 and grade 3 would require STO or UKA, but it will depend on the relative choice age of the patient, which we'll discuss later. But when the osteoarthritis tri-compartment patient would need a TKR. The credit for all this preservation of knee goes to late Dr. Cucino, who had demonstrated regeneration of the cartilage. Now, the factors which are important for decision making are age, stage of osteoarthritis, ligamentous status, type of deformity and reducibility, range of motion, obesity, and general medical status. Now, a word about age. The age criterion has been revised by WHO and followed all over the world with increasing age. 18 to 65 is a young person, so majority of us are young. 66 to 79 is middle-aged. 80 to 99 elderly. 100 plus is long-lived elderly. This also reminds us that we'll have to care for all these patients for a pretty long time, so we must not take a decision in haste. An ideal patient for STO, like Dr. Mittal very clearly said, is a physically active patient irrespective of age. The oldest patient operated for STO has been 94 years. Now we are treating these patients for pain. It is like treating blood pressure without measuring blood pressure, treating diabetes without finding blood sugar. So we must evaluate what the pain is, and which is very simple. In the VAS score, 0, no pain, 2 is annoying pain, 4, nagging pain, 6, distress, intense is 8, and worst is 10. But if you don't want to get into all these details, if we come just to the middle point, moderate pain, patient on the left from 0 to 5, or say 2 to 5 would require HTO, and more than 6 would require knee replacement because it's an advanced lesion. So as said, for a nagging or uncomfortable pain, STO is indication, but patient should have some pain tolerance of VAS 1 because he might have mild annoying pain in a strenuous activity like stair climbing. Pain with instability can also be treated by open wedge high tibial osteotomy. When there is a extension, osteotomy is indicated when there is a flexion deformity or there is a ACL insufficiency. But when there is a hyperextension deformity or PCL insufficiency, the STO could be combined with a flexion osteotomy. Now, depending on the cartilage, when we are transferring the weight-bearing line from the medial to the lateral side must have a functional cartilage. This means either it should be normal, grade 1 or 2. But if it is grade 3 or 4, then the patient would require a knee replacement. But this is very simple. One must understand the MRI are not indicated as they are not sensitive and specific for chondral defects. In a questionable case, valgus stress X-ray is important, and this will decide whether the lateral side is preserved or not. This is very easily done by doing a valgus test and taking an X-ray, AP X-ray of the knee joint in 20-degree flexion. And this is how it looks like. This is the kissing lesion, what Dr. Ravi Mittal was mentioning about. But when we apply a valgus stress, the medial side opens up and the lateral side is still maintained. So this shows that the lateral side is intact, and these patients can be safely treated by STO or UKR. There is no need for any arthroscopy to evaluate this. Patients who have deformity in the proximal tibia, which is taken as tibial bone varus angle of more than 5 degrees, is in favor of STO, and this is measured by taking a mechanical axis line in red, taking a epiphyseal scar and epiphyseal axis in yellow, and if the angle is more than 5 degrees, it's an indication for STO. The unfortunate part is it is quite common in Asians, but the good news is that they respond very well to high tibial osteotomy. The range of motion should be normal, 5 degrees to 10 degrees, but if there's a 20-degree flexion deformity, this can be corrected up to 20 degrees, especially in patients who have high tibial slope of more than 10 degrees. Otherwise, 10 degrees deformity can be corrected when the tibial slope is normal. It is an extra-articular procedure with angle stable implant, and it allows functional rehabilitation, and pre-operative range of motion is maintained. After healing, unrestricted activity and range of motion is allowed to the patient. This is the example of a Japanese study in which 71 patients were able to sit comfortably in Japanese style after open wedge high tibial osteotomy fixed with angle stable implant. Regarding sporting activity, this is the famous case of a German orthopedic surgeon who was a 400-meter runner. At the age of 51, he had 2 arthroscopy and 1 meniscectomy on the right side. He was subjected for open wedge high tibial osteotomy. His alignment was corrected, and 9 months later, he was able to go for 10 days mountain climbing at the height of 6,000 meters without pain. In our day-to-day practice, we would find the patients can go back to strenuous sport after 3 to 6 months. Obesity and smoking is not a contraindication when open wedge high tibial osteotomy with angle stable implant, because the patient can still be mobilized and union is achieved. So the ideal patient for STO would be a physically active patient irrespective of age, tibia bone varus angle of more than 5, intact lateral compartment, flexion deformity up to 20 can be corrected. It gives the patient an unrestricted activity range of motion, some pain relief, some pain tolerance need to be there. And the good part is Asians have that pain tolerance, so they do quite well. ACL and PCL deficiency can be treated, and obesity is not a contraindication. Now coming to UKA, if we look for the age, the Australian registry says it should be done only in 65 plus patients. This is at 50, less than 55. This is up to 60, this is 65. So patients who are at the age of 65 plus, they would do quite well even at 19 years. But in younger patients, it is not good. Patient should not have any osseous deformity because this is a soft tissue surgery, and the tibia bone varus angle should be less than 5. And corrective varus deformity at 20 degree of flexion indicates that the MCL is normal. This procedure could be done because knee joint balancing is not possible in UKA. It should only have an intra-articular wear and an intact lateral compartment, and ACL PCL should be normal because we can't do slope correction. The ideal patient should have a normal range of motion, but should not have any inflammatory disease, and BMI should be under 30. A pagoda type of deformity, when there's a lateral compartment has a slope, cannot be corrected by STO, but they can be very well corrected by TCVO, about which Dr. Milind would tell us. And in these cases, STO is contraindicated. Of course, UKA could be done if other parameters are met. But why we should be careful by doing UKR, we have to understand in Australian registry in 2020, there has been 113% increase in knee replacements, 160% increase in primary knee replacement, 129% increase in revision replacement. But the primary partial knee replacement has gone down by 6%. So with a common sense, we should think why this is happening. To understand it further, a study was done in US, and their direct customer advertising, market pressure, and invent of minimally invasive surgery led to 6-time increase in UK market between 96 to 2001. But it resulted into poor results due to stretching of indications to young patients, more active patients, and more obese patients. And the technical failures were because of surgery being performed with less experienced surgeons who were doing only 2 to 3 surgeries per year. Another multi-centric study done in Canada where 418 patients were evaluated from 79 to 2009. The mean failure time was 6.2 years. The early failures were because of technical reasons, while late failures were because of wear. So we have to understand that we have to be very careful in deciding the right type of patient. So who is a ideal case for UKA? There is a very strict narrow window. Patient should be above 65. There should be mere intra-articular wear, and it should be varus should be correctable. The lateral cartilage should be intact. There should not be any osseous deformity. ACL, PCL, MCL, LCL should be normal. There should be normal range, no inflammatory disease, and the BMI should be under 30. Now, an ideal case for TKA, to my mind, since we have to cater to the age of 100 years, as we have seen in the age criterion, it should be above 75, and patient should be having a tri-compartment lesion, and he should have a continuous significant amount of pain. That means VAS should be above 6, may have extension and flexion deficits, may have excess deviation and bone deficiencies. This can be very well corrected by knee replacement, but they should have limited expectations regarding activity and range of motion. So the take-home message would be STO works. STO stimulates regeneration of cartilage. It is best indicated in medial compartment OA with congenital tibia vera of more than 5 degrees. Biplanar STO with angular stable implant gives fine cleaning at the table, can treat ACL PCL deficiency, allows unrestricted activity, and if need be, it can be easily converted to a knee replacement. Thank you.
Now, is there any question? Dr. Navin bhai, is there any question from audience?
No. There is no much question.
No questions. No questions.
Then I think we should.
Milind has a question.
I have one question for Professor Rastogi, sir. Sir, good morning.
Good morning.
I think this tibia bone varus angle is another unnecessary complication imposed upon us by Europeans. To be very truthful, after reading the article by Hinterwimmer and all those guys, I tried seriously trying to be able to calculate the tibia bone varus angle. And very honestly, I found it very difficult to differentiate this. I am very happy taking the principles of the principles of deformity correction and the standard angles that we know about MPTA, MLD, FA, and the newer angles that we now know from analysis of intra-articular osteotomy. I think this tibia bone varus angle, in my experience, has not stood up to scrutiny as a way of determining, whether you can perform an HTO or not. So I think it's open to discussion and debate, but obviously not here and not now. It's just a comment. But thank you very much for your talk, for a very measured and nice talk.
But Milind, you have more experience in this. My only thinking is, if there is a tibia bone varus at the proximal end, the osteotomy will help better. And they should be not subjected for UKR because you can't align them.
Right, sir. Thank you.
If you allow me to add on tibia varus angle, I feel when we analyze Milind and Mangal and Navin and Smarajit, whenever we do the osteotomy, we take only sagittal alignment in consideration. That is the frontal alignment, and we never do a sagittal or coronal plane deformity. And the posterior tibial slope is more important than your tibial varus angle when you consider the osteotomy, because the moment you have a higher posterior tibial slope, the osteotomy which you're planning, in fact, one of the analysis of closed versus open wedge osteotomy is a posterior tibial slope. So I feel that angle should be considered more importantly than the tibia varus angle or any other angle. coronal plane deformity or coronal plane malalignment in standing axis.
I absolutely agree with you, because if the slope is more, you have a chance to correct it. But of course, the varus is the key factor because the disease is on the medial side, both anteriorly and posteriorly.
Ravi has something to say.
Yeah, this is in response to Dr. Roshan's questions. I think I would be worried about the posterior tibial slope if there is a cruciate ligament deficiency. If the patient has intact cruciates, I'll not be worried about the slope. I will try to maintain whatever the relative slope is.
Hello.
I
Could you hear
agree
me?
with this, because if a patient is comfortable with 12-degree slope, there are no problems in the PCL is intact and ACL is intact. Why change the slope?
I will try to maintain the slope, original slope in my osteotomy. If there is a PCL or ACL deficiency, then I will think of changing the slope during my HTO. Otherwise, not.
Okay. If there is a flexion deformity, how can we correct without altering the slope? Either intra-articular procedure to correct the flexion deformity, Dr. Rastogi.
It can be done by if there's a flexion, then we can do an extension.
Yeah, then slope will be altered. No?
Yes, no, that is allowed. That should be done if it is more than the limits. If there's ligamental injury associated with it. But what I believe and what Ravi is saying, if there is no ligamentous instability, there are two different entities.
Two different scenarios. Now, if you have a preoperative flexion deformity, you can do stretching exercises to decrease the flexion deformity also. And usually that is, you can, the mild deformity correct easily. But if you have a severe deformity, obviously that will not be possible by stretching exercises. I usually do stretching exercises before I do HTO if there is a mild flexion deformity.
In fact, all my patients have to undergo lifestyle modification and exercise program before they come for HTO. Because I want to do this now and forever.
Dr. Milind wants to add something. You are unmute yourself, Dr. Milind.
Yeah, I mean, about fixed flexion deformity. Very nicely put that, physiotherapy first and try not to alter the slope unless there is a good indication to alter it. I have found that particular retinacular releases when there is a combined patellofemoral pain, the retinacular release itself releases some of the flexion deformity. And, sometimes getting rid of the osteophytes in the patellofemoral area and the cyclops zone. So it's surprising that we can get a little bit of an effect and something to keep in mind. Thank you.
Now I think we should turn to Dr. Mangal Parihar to start where the deformity is and how to tackle.
Right. So from what I heard from Dinesh was that this is going to be sort of a 4-part series once every month, and we are going to be discussing, opening wedge, closing wedge, etc., in more detail. So in my talk right now, I'm not talking exactly about how you plan for a high tibial osteotomy, open wedge or closed wedge in detail, for the simple reason that it's going to be covered better. I just want to give a sort of overview in terms of understanding deformity and the sort of principles of deformity correction in relation to a high tibial osteotomy. So we need to look at two terms. One is alignment and orientation. So alignment means what is the relationship of the center of the head of the femur to the center of the knee to the center of the ankle. Normally, these are collinear. They are both, all three, they are in the same straight line. And the second thing is joint orientation. And joint orientation refers to the orientation of the joint line relative to the ground. And for the knee arthritis, the most important thing is, of course, the knee joint orientation, which generally, even in patients who have significant varus, tends to be parallel to the ground. So the first question that we ask, kind of, is there a deformity? Is there a problem? And you notice that all the pictures which Shiva showed were patients looked at from a distance, where even clinically you can appreciate the varus. The same thing has to be done in terms of planning with a full-length X-ray. Today, I think full-length X-rays are available everywhere relatively easily. So that is something that should be done. So when you have the commonly used terms are varus and valgus, when we talk of deformity sort of process of thinking about a deformity, we say a varus, that is a medial or a lateral displacement of the mechanical axis. So the mechanical axis of the limb is from the center of the head to the center of the ankle. Where does it lie in relation to the center of the knee? Is it medial? Then that's a medial mechanical axis deviation, or is it lateral? When it's a lateral mechanical axis deviation or a valgus deformity. Normally, this passes through the center, plus or minus 4 mm on either side. That is there. Another study by Paley shows around 8 mm. So up to 8 mm onto the medial side would be considered as a normal mechanical axis deviation. Now, these are all 3 patients have varus. But the question is it in the femur? Is it in the tibia? Is it in both? Is there an element of soft tissue laxity? Is it in the metaphysis, as was pointed out in terms of the tibia vara? Is it in the diaphysis? A malunited fracture of the femur can also give you an overall varus alignment, and that doesn't need to be treated by an HTO necessarily. And is it a single locus or multiple? So we then come down from mechanical axis of the limb to studying the mechanical axis of the bone, the individual bone, the femur as well as the tibia. And that also gives us the joint orientation line of that particular bone. So if you draw the axis of the tibia, which is center of the tibia, the knee joint to the center of the ankle below, and measure that in relation to the joint line of the tibia, which is the most sort of concave parts of the medial and the lateral condyle, then you will get something known as the MPTA, the medial proximal tibial angle, which is normally 87 plus or minus 2.5. So if it's more than 90, then it is a valgus deformity. And if it is less than 85, then you would say it's a varus deformity of the proximal tibia. Now we are not talking about the entire limb. So there are other angles which are not directly relevant to a high tibial osteotomy, but they are also important, because even an abnormal LPFA, or the lateral proximal femoral angle. So this is the orientation of the hip joint line, which is from the center of the tip of the center of the head to the tip of the trochanter, in relation to the mechanical axis of the femur, or the mechanical axis of the limb. So the LPFA normally is around 90 degrees. The LDFA, or the lateral distal femoral angle, is the angle for the distal femur. So this is normally, again, 87. These are complementary. The tibial and the femoral angles are complementary. The tibia was on the medial side, the femur is on the lateral side. And this LDFA is preceded by lowercase m, which signifies that this is a mechanical LDFA, to differentiate it from an anatomic which is a ALDFA. So this is normally 88 degrees. Anything more than 90 would be counted as abnormal, right? So MPTA we already talked about, but you also have to look at the JLCA, or the joint line convergence angle. If you take the joint line of the femur, that is the most convex parts of the femoral condyle, and the most concave parts of the tibial condyle, you get two joint lines. Normally, these are parallel to each other, or at the most up to about 2 degrees of deformity is acceptable. More than that is abnormal JLCA. So the JLCA signifies a soft tissue component to the deformity. So if you reduce the lower limb bones to stick figures, you will find that all of these joint lines, that is the proximal femur, the distal femur, the proximal tibia, and the distal tibia, all of these joint lines are normally parallel to the ground. And therefore, any corrective surgery that is done, that is a factor also which needs to be corrected, which needs to be taken into account. Now, once we decided that there is varus or valgus, then we need to come to the source of the deformity. That is, which bone is the deformity? Is it in the femur, tibia? So here is an apparent varus deformity. Here the LDFA is 94, which is more than normal. I said 90, and the MPTA is 87. So this is a patient who's got only distal femoral varus, and this patient would be better served by having a femoral osteotomy and not the classical standard teaching that valgus osteotomy has to be done in the tibia and varus osteotomy has to be done in the femur. You have to evaluate each deformity by these principles of deformity correction and then decide what you're going to correct. Similar looking medial mechanical axis deviation. Here the LDFA is normal, 87, and the MPTA is 82, less than 85. That means here the deformity is in the tibia. And though these are line drawings, I'm using line drawings just to make it sort of clearer. But these are cases which all of us, if you look at your full-length X-rays, get very sort of on a routine manner. More often than, or rather, quite often, we get a combined femoral as well as a tibial deformity. A LDFA of 94 and an MPTA of 82. Now this one, if you try to overcorrect the tibial you try to overcorrect for the femoral deformity. If you try to overcorrect in the tibia, one, you will get an extremely abnormal MPTA. Second, you will get a joint line which is oblique. And as I said, that as part of the concept of deformity correction, you not only have to restore the angles, you also have to restore the joint orientation. When this significant varus in the femur and tibia goes on for long enough, the lateral structures will get stretched and you will have a JLCA which is more than 2. So that is something again that you need to, that comes into the planning. You will hear about it more when we talk about HTOs and stuff in upcoming webinars. How do we factor in this soft tissue? Do we correct that, or do we just factor it into the amount of correction, etc.? So the joint orientation, as I said, in the tibia, it doesn't matter whether you're doing mechanical axis or anatomic axis, because essentially those two are parallel to each other. The only thing is the anatomic axis is about 5 millimeters medial. For practical purposes, they are the same. In case of the femur, the anatomic axis is mid-diaphyseal line of the shaft of the femur, which goes from the piriformis to just medial to the femoral notch. And this is different from the mechanical axis, which is center of head to the center of the knee. And normally we say there is an angle of somewhere between 5 to 9 degrees, an average of 7 degrees between the anatomic and mechanical axis. So if you talk of a joint line over here, and if you talk of, we said that mechanical LDFA is 88. So if we're talking of anatomic, then it would be 81. So that is something that you need to keep in mind whenever we are doing the planning. Now, all of this stuff that I have talked about doesn't need to be memorized. This kind of card or graphic is available very easily on Google. You can just download one and keep it for reference. Once you use these numbers 3-4 times, they will all become kind of, you will know them almost by heart. Whether you're doing a mechanical or whether you're doing an anatomic. The only major difference is the LDFA, which is 88, anatomic LDFA is 81, MPTA is 85 in both, LDTA is 89. So this is, all these angles are kind of approaching 90 degrees, which basically tells you that the joint lines are parallel to the mechanical axis. Now look at this guy. They all are varus, but this is a patient who has a normal LDFA, an abnormal MPTA, and the JLCA is normal. So this is a patient who will do well with just a tibial osteotomy, whether you do open wedge, whether you do a closed wedge. There is one more thing which I have not included, but I think Milind will, because that's a little bit of an advanced thing, where the angle or the relationship between the two condyles. Milind will speak about that whenever he speaks of a TC view, and that is something that we need to keep in mind. So this patient would benefit with a simple high tibial osteotomy, whether open wedge, closed wedge, or with a fixator, either. Now, a patient like this with an abnormal LDFA and an abnormal MPTA will not necessarily benefit from only an HTO. They do benefit, but the long-term results may be a little suspect. So in this, with the knowledge that we have now, for this kind of a patient, I would consider a double osteotomy. This is not varus, this is valgus, but valgus also in younger patients give rise to a cosmetic deformity. In older patients, it gives rise to osteoarthritis. So you can notice that this patient has got valgus, but the valgus is from the femur, because 76 should be normally 88, but there is also about 5 degrees of valgus from the proximal tibia. So when it comes to correcting this patient, we would give thought to even a tibial correction, though it seems like something excessive, but there are situations where we will not try to overcorrect one or the other. Similarly, abnormal LDFA, abnormal MPTA, huge JLCA, 8 degrees. So when you will see the calculations in later webinars, there will be a talk. I mean, there will be a lot of discussion on this. What do we do to that soft tissue component? Do we include that in the correction? Do we not include that? But only if you do a full length X-ray and realize exactly what are the angles, then you can sit and think about, okay, what are we to do about that? The final part is, so we decided there is a deformity in the bone. We decided, okay, it's in the femur or in the tibia or both, whatever it is. And now you have to find out what we call the cora, or the place where you want to do the osteotomy, center of rotation for angulation. So one thing you must remember is to draw a particular line. You can either extend a line between 2 points, or you take a line at a particular point from it, you can extend a line at a given angle. So if I tell you on this, from here, you draw another line at 90 degrees, that line would extend like that. So a line can be drawn by 2 points or by a line, a point, and a given angle. So here is the simplest issue of a cora, where you draw the mid-axial line for the tibia, you draw the mid-axial line for the distal tibia. Both these intersect at a point. which is called the chora, and the angle, acute angle between the two is called the magnitude. Now, if you do your osteotomy here and put in a nail into this deformity is going to be corrected. So that's the importance of doing the chora. Here, because the chora comes at the obvious deformity, it doesn't take, too much knowledge or experience to realize that, yes, the osteotomy has to be done there. But when you come to the proximal tibia, for example, there you need to be a little more careful, because technically your chora is here. You will be doing the osteotomy a little lower down, or you do an open wedge like we are doing. So this term you will hear again and again is that the chora comes very, very high in the proximal tibia, almost at the level of the fibula, tip of the fibula. So here, the goal of surgery is to restore the mechanical axis of the limb straight. So you can just extend the femur. In this case, the femur is normal. So the red line is the proximal axis, is an extension of the femoral axis. The blue line is the tibial axis, and both of them meet at the chora. So if you correct this by an angle of 37 degrees, you will get a correction of your deformity. Similarly, for the distal femur, the tibia is normal. You are extending the tibial axis. There is a particular way of drawing the mechanical axis of the femur. You can also do the same thing with anatomic axis planning. And you will find that the chora for this valgus deformity comes pretty distal in the femur. So that will then dictate where and how your osteotomy is done, right? Example sort of problem case, this is a limb which looks straight. So one could well say, oh, there's no deformity, but this girl came with pain in the knee. And in childhood, she had valgus of the tibia. And following the usual maxim that varus osteotomy should be done in the femur, she received a varus osteotomy in the femur. What it led to is an oblique joint line. And the patient, despite a limb which looks kind of straight, she came with pain because of her oblique joint line. Also, this mechanical axis is a little still in varus, meaning excessive correction was done. So probably both of these things contribute to her pain. But if you follow the principles of planning, you will find that there is a proximal axis, there is a distal axis. The yellow one is the proximal axis for the tibia, and the red one is the distal axis for the tibia again. So there is a varus deformity here and a valgus deformity in the tibia. So we corrected that using a nail for the femur and a fixator for the tibia. So now the limb doesn't look terribly straighter, but the bone is straight. More importantly, look at the joint line. It is now parallel to the ground. So her symptoms are fine and she has no problem. So in conclusion, we need to look at all of these things, even if it's a so-called simple HTO that we are doing, where we talk about the mechanical axis of the bone, the mechanical axis of the limb, the joint orientation, especially of the knee, but also of the hip and the ankle, which bone we are going to tackle, what are we going to do about the soft tissue component, use the principle of proximal and distal axes to find out the chora and confirm that the chora is in the region where we are going to do the osteotomy, so that you can decide where in the bone you are going to do the osteotomy. Thank you.
Thank you, Dr. Mangal. Is there any question from the audience? Dr. Shamsul, have you received any questions? In short, what you conveyed the message is that the deformity should be corrected where it is located, right?
Yes, that's right. So, and this is more like a introduction for understanding the more complicated stuff that you all are going to discuss in coming webinars in terms of, you know, the HTO and the DFO, closing wedge, etc., etc.
Yeah. Now I think we should proceed. Is there any question from the faculties? I think we should go further. The next talk is of indications of high tibial osteotomy that I will have to take. Now I start sharing the screen. When I was thinking to talk on the indications of high tibial osteotomy, so the question arises: who is the ideal candidate for high tibial osteotomy? And if we see the guidelines from the ISA KOS, that is a very prestigious Orthopedic Surgeons Association, Knee Orthopedic Surgeons Association, who has said that ideal candidate for who is the ideal candidate for the high tibial osteotomy. What they said, there should be isolated pain either in the medial or lateral joint at the joint level. Another thing, the age should be between 40 to 60 years. BMI should be less than 30. Patient should physically active, so he should not be a very inactive kind of a person. And malalignment should be less than 15 degree. There should be only metaphyseal varus of the tibia that already Dr. Rastogi and Dr. Milind Chaudhary has discussed. It's very difficult to find out the metaphyseal varus of tibia. And there should be a full range of movement before doing high tibial osteotomy. And there should not be any patellofemoral symptoms. And there should be an early osteoarthritis, that is grade 1 to 3. And patients should have a stable joint. It means there should be a stable cruciate and lateral collateral ligament. And patients should not be a smoker. Otherwise, it can lead to delayed union or non-union. So if we find an ideal, if we think of ideal candidate, if we see 100 patients in our OPD, only 10 patients fits into this category. And out of these 10 patients, I think only one patient will get ready for the high tibial osteotomy. In short, this guideline suggests that you don't do high tibial osteotomy in your routine OPDs. So instead of finding ideal candidate, we should search for, if we want to preserve the knee, instead of finding ideal candidate, we should search for the possible candidate, because ideal candidate is same as some persons may say that if a young boy wants to marry and he puts a condition that the girl should be beautiful, should not be too long, should not be too short, good character, it should be from well-to family background, should be smart, intelligent, well-educated, then I don't think he will find that kind of girl for the marriage. He has to remain unmarried for the lifetime. So it's instead of that, we have to accept certain things. If there is age more than 60 degree and patient is physically active, we can do high tibial osteotomy. Here we can see that this is the varus. Patient is above 65. When I operated, it was 67-year-old, and I operated one after the other, not both together. And even at the age of more than 65, even at the end of 10 years, we can see that we can get a satisfactory result and patient can back to his normal activities, even though he is senior citizen. So I think it's not a contraindication, but may not be ideal candidate. If BMI is more than 30, means patient is very obese, then also I think high tibial osteotomy, she can be a possible candidate, because if we can correct the mechanical axis very well, and if we brought the weight-bearing axis near the Fujisawa point, and we should not have any problem, and we can expect a very good result even in obese patient. Probably there might be some difficulty in putting for open wedge with a fixator. I don't know because I don't have that much experience in obese patient with fixator. But in close wedge, it's very safe to do high tibial osteotomy in even BMI more than 30. If varus is more than 15 degree and patient is physically active, then also I would consider it as a possible candidate for high tibial osteotomy. Here we can see that 25 degree of varus on the right side and 18 degree varus on the left side. We can correct very well. We can shift the weight bearing axis near the Fujisawa point, and we can expect a very good result after high tibial osteotomy. Here we can compare the walking pattern, how she was walking before the high tibial osteotomy and how comfortably she walks after high tibial osteotomy. So what I mean to say that more malalignment more than 15 degree is also not probably an ideal candidate, but it's a possible candidate, those who wants to preserve the knee. Here is not a stable joint. We can see there is a dynamic varus. When she puts weight on her right lower limb, there is a varus increases. So this is a dynamic varus. And if we took a full length X-ray in a weight bearing, we can see there is a huge opening of the lateral joint space. So if we if we plan on weight bearing X-ray, we may end up with a very, very high correction that is more valgus. But in that particular case, with a dynamic varus, we should plan, preoperative planning should be done in non-weight bearing X-ray. And after, if we can correct very well, and we can put the weight bearing axis near the Fujisawa point, this dynamic varus will go away. Here we can see in a standing X-ray, there is no opening of joint space on the medial side, and lateral side is also very well. It looks like a normal joint. And if we look the gait after the proper correction, the dynamic varus has disappeared and patient can walk with a stable knee joint. So to treat the lateral collateral ligament laxity, the ideal thing is to do little bit over correction, not too much over correction, but it should be in the lateral compartment. Then lateral collateral ligament laxity can be compensated. So this is another patient with unstable joint. On the left side, we can observe here that there is a lateral thrust while she is walking. There is a lateral tibia is shifting laterally. So this is also not an ideal candidate for the high tibial osteotomy. But if we understand properly what is the reason for the lateral thrust, then we can convert into the possible candidate instead of ideal candidate. And here, this lateral thrust, the reason of this lateral thrust is laxity of the ligament. Here, not a very good video, but still we can appreciate there is too much of lateral collateral ligament laxity here. And medial collateral ligament is relatively stable as compared to lateral collateral ligament. And there is no almost mild laxity of medial collateral ligament. But there is a positive anterior drawer test. Here we can appreciate that the tibia shifts anteriorly in anterior drawer. So there is a laxity of anterior collateral ligament and lateral collateral ligament. So double ligament laxity creates the lateral thrust in this particular patient. And if we can able to correct this thing, on left side, we can see that there is too much of varus. This is weight bearing X-ray. And if we can shift the weight bearing axis near the Fujisawa point, and then lateral collateral ligament laxity will be compensated. And here we can observe that there is increased posterior tibial slope. Dr. Roshan was highlighting on this. So that slope also we have to correct because it will put a lot of stress on the anterior cruciate ligament. And if we brought it to the normal, the posterior tibial slope, if we correct and brings to the 5 degree or so, then this both ligament laxity can be compensated very well. And now after that, we can, if we observe the gait of this particular patient, then there is now no lateral thrust on the left side because we have operated on the left side. This movie has been taken while she came to have a high tibial osteotomy on opposite side, that is right side. So she was operated on the both side, and now we can appreciate that there is a no lateral thrust, right? So I think even with a lateral thrust and even with a double ligament laxity, for me or for all of us, is not a ideal candidate for the high tibial osteotomy, but it can be a possible candidate. Obviously, we have to be more careful while doing correction. And now after doing surgery on the both opposite side also, she can have a full function, that is she can sit on the floor also. So now if there is no full range of movement, then also it's not ideal candidate, but can be a possible candidate, because we need to inform that before high tibial osteotomy, the range of movement was there, the same range of movement will remain after high tibial osteotomy. Because we don't do anything intra-articular in a restricted range of movement. So range of movement, because of less pain, it may increase, but it may remain same. If patient is ready to accept that range of motion is not important for me, and if they get relief of pain, then we can always proceed for the high tibial osteotomy. And if flexion deformity is more than 10 degree, Dr. Rastogi has already said up to 20 degree they can correct by open wedge. But if flexion deformity is more than 10 degree, or is not an ideal candidate, but should be a possible candidate, here we can see that this patient has more than 20 degree flexion deformity. There is a little bit of varus on the right side, but there is more varus on the left side. If we see lateral, these x-rays are in full extension. We can appreciate that there is a more than 20 degree of flexion deformity. If this also we can correct, then also we can expect a very good result. See here how she was walking with a very difficulty, with flexion deformity and a lot of pain in her both lower limb. So if we can appreciate that how much she is, we can correct the flexion deformity by altering the slope. Here I have corrected like that. After surgery, we can see that in the sagittal plane, the weight bearing axis is passing through the near the Fujisawa point on both the lower limb. But in the lateral, this flexion deformity was corrected by altering the slope, not only altering or reversing the slope, and then we can see the clinically that this flexion deformity has been brought to near normal, and varus also has been corrected. And if we look and if we compare the walking pattern before surgery and after surgery, there is a huge difference after that waddling has been disappeared. And this patient is also operated, all the bilateral cases has been operated one after the another, both simultaneously. They are not operated with a minimum gap of 6 months. Even in some of the patients, it was more than 1 or 2 years. So patellofemoral arthritis considered as relative contraindication for high tibial osteotomy, but is a relative. It can be a possible candidate for high tibial osteotomy, because symptoms can improve due to improvement in the Q angle. After doing high tibial osteotomy, Q angle is improving, so symptoms indirectly improves. Or it may need, as Dr. Milind Chaudhary has suggested, may need retinacular release if symptoms are more, and it gives reasonably good result after retinacular release. And otherwise also, if there is a severe patellofemoral arthritis, we have to discuss in the, before doing high tibial osteotomy, that there will be some mild pain in climbing stairs, because patellofemoral joint plays role only while bending of the knee. So during normal walking on weight bearing, there will be no any pain, because we have shifted the weight bearing force on the lateral compartment. So patellofemoral arthritis is not a contraindication. We can always perform high tibial osteotomy, right? Smokers, we can perform always close wedge high tibial osteotomy in smokers with present distal pulsation. If they already have a peripheral vascular disease, then we should not touch that patient. But we can perform close wedge, because in close wedge there is a very, very rare chances of delayed union and non-union. So we should not burn our hand by doing high tibial osteotomy in inflammatory arthritis like rheumatoid arthritis or polyarticular disease, where synovium and cartilage both are damaged. Synovium is inflated and cartilage has been damaged in almost both the compartments. So in inflammatory arthritis, we should not burn our hand. If there is a pancompartmental arthritis, we should not do high tibial osteotomy. And senior citizens with a poor physical activity, and they don't want much requirement of physical activity, then also we should prefer the high tibial total knee replacement or partial knee replacement instead of total knee replacement. If there is any doubt about the vascularity of limb, obviously we cannot touch for any surgery of the lower limb. So usually how I do close wedge, my close wedge is not regular Coventry osteotomy. It's a level at the level of tibial tubercle just below the attachment of patellar tendon, and this is an oblique one. Apex is in the metaphysis and base in the diaphysis. I keep this lateral cortex vascularized as a vascularized bone graft that we will discuss in the separate next series of close wedge high tibial osteotomy. And why should we extend the indication? Is not, even though they are not ideal candidate, why should we extend the indications? Because patient will preserve original God-given knee. Patient can do yoga after high tibial osteotomy, can pray namaz in kneeling position. That probably replacement does not allow, and can do labor work after high tibial osteotomy, even in farm in squatting position, can run if patient is physically active and wants to do jogging daily, and can enjoy outdoor games as a participant. Dr. Pandit sir from Gujarat was always telling in our conferences that after high tibial osteotomy, patient can enjoy outdoor games as a participant, and after total knee replacement, patient can enjoy outdoor games as a spectator only. They cannot participate. So this is the advantage of high tibial osteotomy, and we have an option of total knee replacement remains open if at all required in future. So we are not nullifying the possibilities of total knee replacement. So these are the reasons we should try to extend the indications. Instead of finding ideal candidate, we should find the possible candidate. So again, I want to disclaim that that this surgery is not out of complication. Almost many kinds of complication can happen in high tibial osteotomy, but even in worst situation, there is never an arthrodesis or amputation after high tibial osteotomy in any patients. So this is the very important differentiating factors. If initial surgeons, I think young orthopedic surgeons who have started their practice have not to worry about the arthrodesis or amputation after high tibial osteotomy. That they have feared. I came in the contact with many young orthopedic surgeons because they will have a fear of end results of the total knee replacement. This is not here. So we can safely do high tibial osteotomy without worries of that major disaster. So thanks for your kind attention. Thank you. Thank you. Anybody wants to add anything?
Very nice presentation.
Thank you. Thank you. Anybody wants to add anything or anything from the audience? If is there any questions from audience, or should we proceed for the further? I think Dr. Shamsul has a comment. I think one question is that Fujisawa, about the Fujisawa point, that Fujisawa point, whether it should be on the Fujisawa point or it should be shifting to the lateral tibial spine slope. What is the better option? Anybody wants to, Dr. Mangal or Dr. Milind Bhai?
Essentially, it's the same thing.
Same thing, yeah.
Probably the Fujisawa is the base of the tibial spine. And the what he's talking about is what the newer guys from the newer opinions that are coming in. But Fujisawa point has been shown to work. So I generally use a combination of the two. that is Fujisawa, as well as an angle between 183 to 186. So if it is coming to the Fujisawa point, but the angle is too much, I will reduce it to 186. But ballpark, it goes somewhere around the base of the lateral tibial spine.
Okay.
The next question is from Mozimul Siddiqui. What is triple varus? Kindly throw some light.
Yeah.
Anybody? Yeah, Dinesh, you can tell him.
That is, I think you can better tell him.
Triple varus,
one is in the femur, one is in the tibia, and JLC, joint line convergence.
Soft tissue.
Soft tissue, yeah,
So
joint line convergence.
Yeah. So this is. I mean, I don't think it's really now that we don't. At least I don't use that terminology. Certainly, we try to locate where the virus is coming from, and triple virus is supposed to be a dangerous being because we are not able to perfectly say what we should do about the soft tissue part of the deformity. So that tends to throw us off. Femur X amount you can correct, tibia X amount you can correct, but the soft tissue, it tends to play a little bit of a confusing role. And I think when we in future webinars we'll be talking more in detail.
Yeah,
and Dinesh
Iyer.
Regarding distal femur osteotomy that is commonly done for valgus deformity, does it have any effect on patella tracking and Q angle? Should that be taken? If anything, it has a beneficial effect. In fact, if you look at all the valgus deformities, they will have a slight lateral maltracking of the patella. And the moment you correct that valgus maltracking goes away. In addition to that, if there are other issues such as hypoplasia of the lateral condyle, then you may need to address that. But usually, if you're doing it for an adolescent valgus who usually doesn't have pain, they come primarily for deformity, where I would do just a correction of the valgus and leave additional patellar procedure if required for the future, if and when they have pain. I haven't had, in the last maybe 10 years since I've been doing it, I haven't had anybody come back to me for significant patellofemoral pain. Milind, any thoughts on that? Valgus deformity and doing a patellar procedure, or how do you take it into consideration?
Yes, you're right. One has to take into consideration the rotational issues in the rotational malalignment and its effect on patellar tracking. And a thorough, careful clinical examination, which includes rotations of the hip in flexion and in extension, tracking of the patella, on flexion, keeping a thumb on the lateral aspect, and taking into consideration this thing called as the miserable malalignment syndrome. All these things are a part of.
Like we were said. Just I have a couple of questions for you. Which portal do you use for
Roshan, you're
right?
He's on
you're listening to something else.
He's on another webinar. He's on a dual wicket.
No, I'm not on dual wicket. Basically, my laptop I'm unable to see it sometime. I'm sitting in a very net affected area.
So I think, should we go further now, Dr. Milind? Yes, large deformities.
So, good morning, everyone. Can you hear me, please?
Yes.
So, thank you very much. The dynamic view of Dr. Shivashankar and Dr. Navin Thakkar. Thank you, Dr. Dinesh Thakkar, the chairperson of the Hip and Knee Preservation Subcommittee of IOA. I'm very happy to be a part of this interesting series. High tibial osteotomy in large deformities. My question is, why TKR necessarily? Now, we have patients coming to us in our OPD who look like this. And many of them, of course, have been offered total knee replacement, but they don't want it for some reason or the other. People are not foolish. People have heard from their neighbors, from their relatives that we've had a total knee replacement and so person is not entirely happy, so on and so forth. And even the literature says that up to 30% of people can be unhappy. And I will be telling you some anecdotal instances of this very soon. So what do we do about these people? Do we just neglect them? No, obviously not. When we take full-length X-rays, we see that the mechanical axis can deviate mildly or even severely. And that gives us a clue that this is a large deformity. And as Mangal has very nicely analyzed, we can decide, where is the deformity and where we need to tackle it. So this is something I would like to emphasize. In the Lord and Tricky lecture in 2013, the elder statesman of high tibial osteotomy from Switzerland, Rolly Jacob, stated that the standing single length plane X-ray is the most important diagnostic modality in osteoarthritis of the knee rather than MRI scan or arthroscopy. We have to emphasize this because our colleagues in general orthopedic surgery take small X-rays. If the patient doesn't have relief, they send him for a MRI scan or they say, let's do an arthroscopy. There are stories that I'd like to share with this. So it's not just the large deformities that need consideration. I want to share the story of this pathologist, lady from a district place. She had pain in the knee at the age 47 and she was, told to go to the city, the big city, the Oxford of the East, where they have these conferences. And she was told, you need an arthroscopy. And she had a, moderate varus deformity. And after arthroscopy, she had no relief. So after 5 months, she went back to the city and the surgeon said, this has happened, that has happened. Now let's do one more thing. Let's get another MRI scan. Let's do another arthroscopy. Being a really nice person, she agreed. She's a doctor, her husband's an ophthalmologist. The second time they had an arthroscopy, she had no relief whatsoever. Again, after a few months, she goes back and she's told the same thing. This has happened, that has happened. Let's do arthroscopy again. So they ran away. And her daughter's wedding was 5 months away. And that is how, they got in touch with me. And all this lady needed at this age, and this is a common conundrum, all she needed was a routine medial opening wedge high tibial osteotomy using the Tomofix implant, which is extremely reliable, allows early weight bearing, gives an accurate result if you do the proper planning. And her daughter's wedding was successfully conducted. She's very happy 5 years down the line. Here she is with really no problems whatsoever. This is the story, another story of a mild deformity in an orthopedic surgeon. He has had ACL injuries and some suspected tuberculosis. And he was very unhappy because he wanted to run. And people were saying, no, we have to wait for a total knee. And he says, I want to run. How it is. And people, young people who are 40s and 50s, and so many of us young people in our 60s want to do things. So, all he got was a high tibial osteotomy. And the thing to remember in athletes is not to overcorrect. So I'm sorry the video is not working, but just last week he sent me a message saying that he has run 450 kilometers in the last week. This is 3 years after surgery. And he's 47 and he's an orthopedic surgeon. I have pictures of him running and exercising. So now let's come to the main topic, which is large corrections and large deformities. This is what people are afraid of, and they say that it needs a total knee replacement. Nothing could be further from the truth. There are various methods that we can use and correct the deformity using different hardwares at different locations, depending upon the comfort level of the surgeon with that particular hardware. So this is just a very brief glimpse. Take a visual look at the whole presentation. So this is a lady with a large varus like this, very mild varus in the femur. Much of it is in the upper tibia. So we chose to perform a medial opening wedge. Now the Irisar is rather versatile, and you can see that the hinges on the lateral side are accurately at the apex. And a gradual correction of this after release of the MCL gave her a very good correction like this and slightly overcorrected. She's free from pain for more than 10 years. Another lady, she's 60, she has bilateral severe varus deformities. And this diagram on the left shows that if I were to perform a medial opening wedge, I would have to create a really large wedge acutely. So it's better done gradually And again, this was done with the Elizarov fixator very nicely. It doesn't matter. The Elizarov fixator, when it's pain-free, it's very comfortable. And correction on one side, correction on the other side. And here she is 12 years down the line, very comfortable and free from pain. Now let's come to the focal dome osteotomy, which was my primary, treatment modality for the first 16 years of my practice, from 1991 until 2006 almost. I exclusively used the focal dome osteotomy with very good results. Here is a 65-year-old ex-bodybuilder who has got a varus. It's in the upper tibia. There is an intorsion as well. So you can see with the focal dome, it's a nice curved shaped osteotomy. We get a little lateral translation, a little external rotation of the distal fragment. The patient is walking. The Elizarov allows compression at the osteotomy site for a very reliable union. Of course, you have to perform a proximal fibular osteotomy to permit this lateral translation and compression. Very reliable result. This is a professor and head of the Department of Medicine at a medical college. This gentleman is 59 and he has had a malunion with a little bit of shortening, varus and intorsion. He was of course told he needs a total knee replacement, but being a very active physician, you can see his hair is all jet black despite his chronological age. So we chose to perform the focal dome osteotomy with the TSF fixator, in which we brought him out into valgus. We externally rotated the tibia and added just that little bit of 1.5 centimeters of length that he needed to equalize his limb lengths. 3.5 years after surgery, is absolutely fine, can sit on the floor, can go about his activities and has no pain whatsoever. So now let's come to the really large deformities like this. This is a lady done about 20 years ago. She has this severe deformity. Look at the mechanical axis. Well, then I did not know about the intra-articular correction, but I chose to do this with the focal dome. You can see that the dome osteotomy permits us to translate the distal fragment laterally quite a bit and without losing bony contact and compression. And she has a wonderful result and is free from pain for a really long time. The beauty about the Elizarov is, of course, that you can also perform bilateral at the same time. And this video is not working, but the gentleman can easily walk about and do his business. So that's the beauty of the Elizarov. You can have reliable compression. You can correct the deformities in the tertiary plane, that is sagittal, rotational, and axial planes also, and correct a large varus. It takes a little bit of an effort. There is, of course, a learning curve. A high tibial osteotomy is not a cheap and simple surgery like they used to do in the days of the Coventry, wherein people took pride in performing the surgery in 15 minutes. So this is also written up in the literature in JBJS American. This is a 16-year-old follow-up of subtubercle, that is a focal dome osteotomy. It's a very reliable osteotomy. And if you take the trouble to learn the tricks of the Elizarov fixator, you can solve many problems that the patients have. But the problem with the Elizarov is that the older people and some people are not very happy with the idea of having a fixator on their leg. So why not use the beauty of the Elizarov fixator in the operation theater alone? So this is what we did. This is a gentleman. This is a nice story because I did this as a demo surgery in 2010 in the first National High Tibial Osteotomy Conference we held at Jaslow in April 2010. And this is the surgery that we did. I remember everybody had a rollickingly good time because I was having a tough time in the OR with my assistants misbehaving. And the surgery took much longer. But this gentleman is doing just fine with bilateral surgery. He can squat, he can do everything. This is now 11 years after surgery. The large deformities are corrected with the lateral plating. And look at somebody like this. She's 70. She has this large deformity. And, my arthroplastic colleagues are going to be rubbing their hands with glees. One more Musca case for me to show. And the patient said, no, we don't want a replacement. So I did a fixator assisted plating. This is done long ago, 10, 11 years back, when I did not know the intra-articular. And the correction is not beautiful. I agree. But this lady is free from pain for the last 7 to 8 years. And she has no problems whatsoever. I really don't know why the video is not working. But you can see in our language, in Marathi, they say, Matari turu turu chalte. You know, she can walk fast, she can walk several kilometers, and she's really free from pain. So the large deformities need not necessarily be a deterrent. Now we also learned to perform the fixator-assisted dome osteotomy with a medial plating. So this is a lady, this is the question people ask. This is a large fixed flexion deformity, and you can see her x-rays. This is the small element of lateral subluxation, flattening, the osteophytes, etc. The typical picture. There isn't much of a deformity in the femur. And so we chose to perform the patellar retinacular release. You see the incision here. The patellar retinaculum is released and a fibular osteotomy is done. The fixator is, first we outline the osteotomy with a sharp osteotomy, a smiley osteotomy. The fixator is applied and we complete the osteotomy with a medial, because this way on the medial side you can release the MCL, and that allows the medial compartment to unload. And here she is with a very good correction of her FFD without altering the slope, and a very good relief of pain. This is another lady with bilateral problems. We started on the first one we started on. So this is how she's walking. She's utterly miserable, and she has a lot of pain. She's 65. She was of course told a total knee, and she just doesn't want one, and it's not necessary. So again, we did a dome osteotomy and fixator assisted plating on the medial side. It allows us to release the MCL, the retinaculum is released, and they get a reliable result. She comes to me the next year with the pain on the opposite side, and this is where we performed the intra-articular osteotomy, which I will briefly dwell upon. And in the next few series, we will be discussing this at length, because now we have an experience of more than 50 of these for the last 6 years. So here she is. This is, both her knees are corrected, and this is her video walking, you know, turu turu chalte. And she can sit on the floor and she's absolutely no pain whatsoever. So before you guys get worried that the lateral compartment is looking a little bit like this and a little bit like that, I'm telling you, Dr. Koshino used to say, you know, God, may God rest his soul in peace. He passed a couple of years back. He told me, you know, just because the lateral compartment doesn't look great, it doesn't mean, there's very few cases are truly tri-compartment, and you should give it a chance. And I would go as far as to tell you, I've been saying this for so many years, dear friends. I think the high tibial osteotomy should be the most commonly performed elective orthopedic surgery of all, because so many people deserve it and can give a good result. Now coming to the double osteotomy, what Mangal nicely pointed out, this is a gentleman with a deformity in the femur and the tibia. And he's miserable, he can barely walk. You can see he indeed has an MLDF of more than 93 degrees. So it does deserve possibly a femoral correction. And this is exactly what we did. We performed a closing wedge femoral osteotomy, which allowed the joint line to get a little better. This is the lateral X-ray. And in the second stage, performed an intra-articular osteotomy for his tibia, as I had shown a little previously. And that gave him an excellent correction of the mechanical axis, just to neutral. And this is him, you know, walking in his house very well. This is his left lower limb. He has absolutely no problems. He can sit cross-legged. He can almost squat for some time if the need arises. And he's completely free from pain and will come to do the surgery on the other side. And this is another gentleman who's been having these problems. And he was telling me, you know, I'm going to come for surgery one of these days. And then one day he falls down and gets an intertrochanteric fracture. So he comes to us. So then what we did was, after we put on the DHS on the top, and we used a fixator assisted plating of a distal osteotomy, performed a distal dome, because I didn't want to perform an open surgery. The LRS, small LRS fixator with a clamp was applied on the medial side, and we did, with minimal incisions, we did the dome osteotomy, and with a small MIPO procedure, we slid in the lateral plate, and notice the medial translation of the distal fragment, and you know, he got a good correction. And a few days later, we performed the intra-articular osteotomy of the upper tibia. You can see some pictures. You can see how under the C-arm control, the osteotome just about broaches the articular surface. We take great care of the posterior cortex and the intra-articular surfaces to make sure that we are able to get good collinearity of the tibial condyles. And here is the gentleman with his Notice this is his right lower limb, he's just fine. This is his analysis, he's just come to neutral. And nowadays I'm not very, very fond of overcorrecting in many cases, because considering the basic nature of this talk and the introductory nature of this talk, I didn't want to get into great details, but it is not absolutely mandatory. If you can retain the correction, number one, with an internal fixation device like a plate, that's not going to go back into varus, the patient will have long-term pain relief. If you're going to correct any intra-articular deformities, the patient is going to have long-term pain relief. And if you're going to, take care of the gait and the other small aspects that the patient has, don't get worried if the patient comes back to you in or out patients and complains of some pain after HTO. Make sure that the hemoglobin and vitamin D levels are maintained. Very frequently they're not. Make sure the uric acid levels are not elevated. Frequently they are. And make sure that you train the patient to walk properly. Gait analysis is a little understood and much neglected aspect of the treatment of medial compartment osteoarthritis. It's an entire talk in itself. I have been focusing on this ever since 1991, following the work of Tom Andriachi, who's a mechanical engineering professor at Stanford. I'll make the patient walk with slight out-toeing, shorter steps, and some knee flexion on the first part of the stance phase of the gait. Don't allow the patient to walk with a hyperextension gait, which is what's known as the lateral thrust. And this is how you correct it. You can correct it in surgery by overcorrecting with the focal dome osteotomy. You can correct it in surgery by externally rotating the distal fragment, and you can train the patient. So this is how they're going to get good results despite their large deformities. So briefly look at the TCBO written up in very few journals in the English language literature. First in 2015 in JLLR by Professor Teramoto, who was one of the original students of Professor Chiba. So I'll focus on the large deformities. So we use it in combination like this. This is the deformity. We perform 2 osteotomies and translate the distal osteotomy till we get a good correction of the mechanical axis. And this is a lady with this very large deformity and horrible looking tibia, atrocious gait. And you can see she has had stress fractures over here. So she's really a good candidate for this kind of surgery. And here she is with the Elizarov fixator. We do a combination procedure, intra-articular and an extra-articular varus correction. And they really can get a very good correction of their, even though it looks in much more valgus on the X-ray, clinically, she's just in the right amount. It's taken care of the dynamic, varus gait, and she's free from pain for the last 4 years. Now, this is a gentleman who had a total knee on one side. He's 65. He came to us, and we first did a plating because we didn't learn about, doing the combination osteotomies long ago. And, here he was, sorry, the video doesn't work, but we performed the plating first, and then to give him an adequate correction, we later on removed the plate and did the Elizarov before we learned to do the combination procedure. There is no harm in redoing your stuff as long as you don't overcharge the patient. And if they have faith in you, so he had a lot of faith, and he had then tolerated the fixator really well. He got a good just lateral translation, and here he is, he can squat down, and here is his, his video. He walks really well. He has absolutely no pain. This is actually the plating x-rays from before, but he's fine and he's happy with the HTO side. And, so don't think that the total knee replacement is the advance of the last century or this century. High tibial osteotomy, the developments are taking place at a breakneck speed. The amount of literature that's coming out on HTO, whether it is on MOW HTO, whether it is on newer forms of high tibial osteotomies, whether it is starting with Babis, who told us in 2002 that you need a double osteotomy. He's from Mayo Clinic. Or Saragaglia from France, who talked about navigation and a double osteotomy, to the intra-articular osteotomy. Do you know that intra-articular osteotomy started in Japan in 1989? And they have done thousands of these, even in older people. So There's so much exciting stuff going on in high tibial osteotomy, and you will be amazed. With a little bit of application and patience, you can give your patients really good results. I will end with this example of this professor of English who has poliomyelitis and a very severe valgus deformity. Now, what do you do for her? If you carefully analyze, there is a high neck shaft angle. She has a valgus in the femoral neck. But at this stage, I don't want to deal with it. And she has a very large intra-articular deformity, a very high JLCA. So this is what we chose to do for her. We chose to perform a lateral TCVO, opened it up until the condyles become parallel, and then added pins at the intermediate level and a distal osteotomy, which allowed us to translate the distal fragment medially with the help of a TSF fixator. We used a 5/8 ring above, so she was very comfortable in the fixator. And at the end of the procedure, this is how she's walking much better. She has no pain. And at a later date, she may get something done at the hip, but in all probability, with the mechanical axis going towards the center of the knee, she's not going to need anything. So, my dear friends, I wish to reiterate and tell you that high tibial osteotomy is here to stay. High tibial osteotomy did not develop long ago when arthroplasty started. People were doing crude forms of high tibial osteotomy with staples or very inadequate understanding. Now our understanding of deformities, whether they're in the femur, whether they are within the joint, we have 4 different angles with which we calculate an intra-articular, deformity. The condylar plateau angle, the JLCA, the spine edge angle, and the vertical distance to the spine. We are able to tension the cruciates, leave alone the slope correcting osteotomies that Roshan and other sports surgeons do. There's a whole world of reconstructive surgery waiting for you. Thank you very much for this opportunity and the time you give. And I end exactly at 20 minutes. Thank you.
Thank you, sir, for showing a lot of cases of high correction. Now I think, I don't think, is there any question from the faculties? Because yes, Dr.
Before the question from
yes.
Dr. Ravi Mittal, I want to congratulate Dr. Milind Chaudhary. He has been invited for presidential oration of the North American Limb Lengthening Reconstruction Society. Congratulations, Milind.
Congratulations
on behalf of
from
all
all
of us. That's a really great achievement. You are taking Indian flag everywhere and you are making us proud. Congratulations.
Thank you. Thank you.
Can I ask question, Milind, on
yes, please.
TCVO?
Yes, please.
Yeah. So I just wanted to ask you, when you do intra-articular osteotomy, nothing against osteotomy, even I had done few after seeing US results. What is the chances that a common outcome of intra-articular fracture is stiffness? So here the man-made created fracture or osteotomy. What are the chances that patient will have a post of knee arthrosis as regards to the corrective osteotomy, because you're already putting a lot of implant next to the joint. Secondly, you're creating an intra-articular osteotomy, changing the alignment with so much of issues, because whatever experience I have of 3 cases of TCU, I think 2 of my patients had landed up with a severe arthrosis.
Yeah, I mean, Roshan, all of us have a learning curve with that. And, if you persist, don't mind me, I don't want to, sound patronizing. But intra-articular osteotomies have been around for a long time. In Blount's disease, we have had the, the Langen-Schuld osteotomy. Actually, Dror has written about intra-articular osteotomies in HTO as early as 2009. And the Teramoto and Professor Chiba, who started it in Nagasaki, and Professor Teramoto have done thousands. Now, the difference between a traumatic and a surgically induced osteotomy is that the traumatic is very, high forces. As I showed you in my x-rays, we do it very carefully. It's done very gently, very gingerly, and the osteotomy barely penetrates. And of course, you use gentle technique, and your plate is starting a little of a centimeter below, and immediate mobilization. We are not keeping the patient immobile. Whether it's the Elizarov as in a double osteotomy or a single osteotomy with a plate, which I do equally often. So I'm very sure, Roshan, you persist and you will overcome these hurdles. I'm very sure about it. There are many things to be learned, and there is a language barrier with the Japanese. They cannot convey a lot of things. I'm learning, almost every month, every year, I'm learning many new things about it.
May I ask you a question?
Yes.
Chaudhary. I've been listening to your talks and Dr. Parihar's talks and learning about the osteotomies. Now, when I see your presentation, you could correct a lot of big deformities by focal dome osteotomies. And so I just like to know, how do you select your cases that this will be okay with focal dome and this needs TCVO? How do you select that? Because I see equally good correction with both the two procedures.
Right, Professor Mittal. So, very recently in the VIROC of Bombay Orthopaedic Society, a paper won the Masala Wala, because now we've come to the understanding of which osteotomy goes where. So now the focal dome osteotomy that I perform is reserved. See, so now we've categorized deformities into primary, secondary, and tertiary. The primary is the varus, which may be mild, moderate, or severe. The secondary or the second deformity is the intra-articular, which is less recognized till date. And the tertiary deformities are the axial, sagittal, and rotational, meaning the patient may have a leg length discrepancy, he may have a rotational deformity, or he may have a, in the sagittal plane, as in a slope problem. So the focal dome osteotomy, when fixed with the Elizarov or when done as a fixator-assisted plating, allows us to correct large, moderate, or large deformities of the primary variety, which is varus, but not the intra-articular. And it allows us to correct the sagittal, rotational, or axial deformities. So that's when I will choose a focal dome, either by itself with an Elizarov or as a fixator-assisted plating. Primary and tertiary deformities. There has to be no intra-articular deformity to perform a focal dome. Now, if there is an intra-articular deformity by the pagoda tibia or a slope in the tibial joint line, the medial and the lateral condyles are at an angle. We have 4 angles now. I will talk about it later. If there's an intra-articular deformity, if there is a mediolateral laxity, which you can observe in gait or on the table under anesthesia is exaggerated. Many times on the table from medial opening wedge, I've gone to an intra-articular because there's a significant laxity. And we can elevate the condyle, make it collinear, increase the surface area of contact between the tibial and the femoral condyles. So it's dramatically increased. And that's when we do an so the secondary presence of the secondary deformity is an indication for an intra-articular. Now, when should your mind be alert? So we found there is a high correlation, R equal to 0.62. When the mechanical axis deviation is more than 0, that's 0.62 correlation is there, that there will be an intra-articular deformity as measured by a condylar plateau angle. So whenever you have a full-length X-ray, with the mechanical axis not touching the joint, be alert that this could be partly or completely an intra-articular deformity. There may be upper tibial and lower femoral deformities along with it. So that's how we decide. And the really small ones get done with the Tomofix.
Okay. Now, I was reading about TCVO. The basic difference that I could find was that HTO talks only about the mechanical alignment, whereas the TCVO talks about the mechanical alignment along with the congruency of the joint. Am I right?
Yeah, absolutely right. Yeah, that's right. So it's not the primary aim. The TCVO, the whole difference of thinking now, we have to start thinking in many different ways. It's not just alignment. You see, it's multifactorial. And what's happening is that by allowing this, so pressure is equal to force upon area. So from a point contact on the medial side with the teeter-totter effect of the joint, from a very small point contact area, you're broadening the contact area, and that takes away the pain. And there's an instability during walking. So there's much that we have to learn, and we are finding out more, so the tendency is to try and do only one type of osteotomy for everything. So we have to now learn to discriminate. So the TCVO has definitely alignment and congruence and stability as factors that help in correcting the pain.
Okay, one more question. When we had a varus deformity and Dror Pale was talking about the elixir of correction, he also talked about tightening of the lateral collateral ligament by pulling the fibula down. Am I right?
Yeah.
So
Yeah, you're right.
are we still doing that, or we have just given up on that?
I don't know, Professor Ravi. I gave up on that 25 years ago because I found after doing the surgery very diligently, I did it on a professor of pathology, I did it on several people. I found pulling down the fibula as for the lateral thrust, after some time it loosens up again. So that's not the only thing. What I found reliably was with the long ago over-correcting was helping get rid of the dynamic varus and the lateral thrust. And now we have found the TCVO. So very honestly, with due respect to Dror, it didn't work in my hand. So I gave it up long ago.
Okay, thank you very much.
I don't think it works in Dror's hands either. To my knowledge, he doesn't do it anymore.
But if I can add, lateral thrust is a part and parcel of varus malalignment of the knee joint. Do you really want to correct that lateral thrust by fibula, getting fibula back down onto the fibula head and tightening the lateral thrust?
Actually, I don't recommend it. There are other ways to correct it. Is by gait.
The moment you correct the malalignment on medial side with the medial open wedge or lateral closed wedge osteotomy, your lateral thrust will go away.
Exactly. So once you've discovered that, that fibula thing is not used anymore. It's a basically it is improving knowledge and understanding. As we get better at understanding the pathology, we are correcting that. And even if there is a particular case, where there is a gross laxity and after correction also you find that there is, because it's not only the lateral collateral ligament, it's the entire posterolateral complex kind of which is stretched. So I would actually favor excision of maybe 8 or 9 millimeters of the proximal fibula. Leave the tip of the fibula with all its attached things together. Excise 5 to 8 millimeters of the proximal fibula and acutely advance the tip of the fibula with its attached structures. That will give you a correction of that laxity right away. But that's only if our angular correction has not done what it needed to do.
Okay, there are questions from the audience. Dr. Dinesh Iyer has asked another question I have, sir. Is there any specific advantage of using specific osteotomy plates like Tomofix, or can it be used other commonly used available proximal tibia plates with comparable results? Tomofix or any other plate, routine proximal tibia plate can be used?
No, you can't.
Okay, I will answer. Okay.
Go on.
Yeah, so Tomofix plate is an angle stable implant, and if we use original implant of Synthes, so it works as an internal fixator rather. I also use in close wedge Tomofix medial locking plate, so it works as an internal fixator. So we can allow weight bearing earlier. Even in the next day, I am allowing on the next day the partial weight bearing with an original Tomofix implant. What happens in other plates, other locking plates, the duplicate Tomofix or Indian made Tomofix, whatever we say. But in that, I have experienced that if I have allowed them to partial weight bearing in earlier phase and patient puts up more weight on this, that locking thread breaks away and the screws comes back from the Indian Tomofix. So that is the advantage of original one. That's all I wanted to tell. Other locking plate probably is not angle stable that much. What others has to say?
Additionally, the Tomofix plate is made specifically for this opening wedge. When you use it for an opening wedge, in the sense, it's a thicker plate than what you would use for a fracture, for example. the intervening area which bridges the open wedge is a solid thing. There are no holes there for failure, etc.
Material is different. The metal is little
And
bit
the
different.
material
Palladium and
yeah,
is added more.
correct.
And
So
it has a elasticity also.
yeah. So you
It
can't
allows us to move.
you can't mix. So if you do a closing wedge, for example, probably you could use any plate, just moderate the weight bearing, as Dinesh pointed out. For an open wedge, there are other plates which are available now. Especially there are many low profile implants, but they also rely on an interposition graft. So Tomofix is not only a plate; it's a complete kind of system. So it includes the implants, it includes the technique of the osteotomy, which is a biplanar osteotomy. The biplanar part gives that stability. So you can't divorce the implant from the way you do the osteotomy and all the other things that have come from it.
Instrumentations are synchronized with the implant.
Yeah.
Can I add to that?
Yes.
Hello. So I feel there are two religions here. One who follow the trauma as basic principles of management. They follow the Tomofix, but people who are from the sports medicine and knee preservation group, they will follow the other kind of plates like Hoodoo plates, which are commonly used for medial open wedge osteotomy, or the conventional counter lock, or the peak plate, peak power plate, or you have active motion, or you have the eye balance plate, or you have dual plate from Escalab. So these are the different plates which are commercially available for osteotomy. Out of that, certain plates has been studied, and this is a very famous study. Since I made a presentation on this plate, so I know it. This study was by Pape and by Dr. Maas, and they have found out the static compression load failure test for medial open wedge osteotomies, and they found out that Tomofix has got very less static compression failure rate as compared to the other. And this is very important as regards to keeping the hinge intact on lateral side. The moment you have hinge intact, these plates will have a better role, especially the Tomofix. And the Puddu kind of plates are very, very important because these are wedge plates where you have an inbuilt wedge, and they will give you a initial stability. And when you use the like Dr. Milind was saying, that you don't require bone graft whenever you use Tomofix. But whenever you have a gap more than 8 to 10 millimeter, it is advisable to use bone graft. You can't, the osteoblast cannot jump this distance. The jumping distance is very, very high. And you have very high chances of non-union when you have more than 10 millimeter gap, which is created by Tomofix. So this is in short what I wanted to contribute. And
no, I have to correct that. Correct that. The osteocyte doesn't jump across the gap. Tomofix larger gaps also fill up. That's what I said, that I agree that for you don't have necessarily have to use a Tomofix. There are other plates which you use, but they have their own technique. So if you want to keep an open wedge, and more than 12 mm also people are doing an open wedge, that area fills up with a coagulum, and then the mesenchymal cells heal into that. There is a whole sort of, if you study that, it works. So it's not that the Tomofix fails if you keep an open wedge for larger distances. It gets through. In fact, there was a paper by the original Saubli, etc. group, which looked at the role of interposition materials. And they found that adding any interposition, especially synthetic graft, I mean, bone graft is fine, but adding any synthetic graft actually retarded the healing compared to just leaving it as an open wedge. So they have that technique where you release the tunicate, you do the wash, release the tunicate, that whole thing fills up with a coagulum, and then you don't disturb that coagulum. That is kind of critical, and most of us have sort of realized that looking at the original this thing. You agree, Milind, Sanjay?
Yes, I totally agree. But things which have to be understood is, in the ascending osteotomy, that area is already in contact, and that starts showing union from the day 6 to day 18 already. The lateral side, which has been cut partly, will be under compression because of the screw put in the first hole. So the healing is much faster. Of course, it is from anterior to posterior and from lateral to medial. The medial gap might persist, but the stability is there because of the anterior contact, the bones are in contact, and laterally by compression. And the other thing is, it also allows certain amount of micro motion, the motion it takes place in Lazaro. That also promotes healing. And I will slightly disagree while I was working with Stobley. They say you should not wash that area. You apply a compression bandage, let the hematoma retain, and just apply a plate. And that's the reason you don't put a vacuum drain, you put a overflow drain, so that whatever has to just come out would come out. So I think basically, as you rightly said, it is a whole system of tomofix. You have to understand the implant, the technique, and then work on it.
For the benefit of all of our viewers, I would like to state that the important thing is that the alloy, Dr. Navin Thakkar alluded to this, is a titanium niobium alloy. The trauma plates are titanium, vanadium, aluminum. This is a titanium niobium aluminum alloy, and it's actually very strong. Even with a big German plate bender, you find it hard to, there is no need to contour this plate, but I'm telling you, it's very strong. And it gives greater elasticity. So the environment that Mangal was talking about consists of the plate on the medial side, the hinge, and the screw over here, and the golden screw having achieved compression at the hinge. The elasticity of the plate and the golden screw has pre-contoured the plate like this. And it wants to come back to its original level. When it wants to come back, it is exerting more force over here. And there is an elasticity with weight bearing. So the entire thing, with the special alloy, the elasticity and the compression at the hinge with the golden screw, it sets up the osteogenesis. So the good news is that Surgical also makes the titanium niobium alloy plate. I've been after his life, and after 5 years of pursuing it for the last several years, he now has, his plate also has titanium niobium. You could safely use that.
This is from
Uma.
Right.
Uma Surgical. Yeah.
So we are not basically, sorry, Ravi, go on. I'll talk after you. Ravi, go on.
See, I think the two basic advantages of tomofix is that you don't have to fill in the gap with the bone graft, and you can start immediate weight bearing. Now, if you are not, the patient is not affording, you can still do the open wedge osteotomy, fix it with any plate that you want, or the patient can afford, but fill in the bone, the gap, the bone graft, and allow delayed weight bearing. You can allow knee motion, but not weight bearing. That's what we have done in some instances also. So you can use any plate, but you fill in the gap and delay the weight bearing.
Agreed.
Yeah, I agree. So we are not selling or promoting tomofix. There are other plates also which have been shown to work well. As Roshan pointed out, there are other plates which are strong, but each of them has their own technique or issues that you need to take care of. And usually for most of the other plates which are low profile, which are probably not as strong as the tomofix, you would need to use some form of interposition material, and bone graft is the best interposition material. Some of them talk about, Roshan, you use some artificial substitutes also.
Yeah. I have used, whenever I do any osteotomy which is more than 10 to 12 millimeter height, open wedge, I always do the artificial tricalcium phosphate.
So
block.
there are different ways of approaching it. The point was just that, tomofix, open wedge, without graft, each of these things you have to keep in mind. It's not directly translatable. कि tomofix नहीं मिल रहा है और tomofix का surgical technique देख लिया, so I will use a cheaper or a less strong plate. Then you can land up with trouble.
Yes, that's why, Mangal, when I was talking in my talk, I clearly said that my preference is for fixator assisted. because it saves a lot of cost. Basically, the question is regarding the cost of the implant and the instrumentation availability. So fixator assisted takes care of all of them. So there is no necessity of removing the implant. You can achieve the complete correction. You can get whatever the length you want to get. 15 millimeter, 20 millimeter opening also will be covered by the regrowth regenerate. So that's why I'm more inclined to use a fixator assisted HTO rather than a robotics.
Anybody has an experience? There is a question. Somebody is asking, can I add a small lateral plate for get the stability if I using a routine plate?
I have an experience where I have landed up with a TKR type 2 type of fracture on lateral side. So medial side was a plate and lateral side I have to use a smaller plate, the lower end radius plate. I used it with a small incision on lateral side. And I think stabilizing both sides is very important when you break the hinge completely and creating an instability on both sides. So I think the preservation of hinge is the one very important aspect whenever you do osteotomy. And probably there are techniques where we can preserve it by prior drilling it on the lateral side so that you can crack it just crack open, or you can leave it as it is as at the level of fibula. So whenever you open the hinge and you create a lateral fracture, lateral cortex fracture, either a small screw from lateral side, or if it is a big fracture like it is going down or going up. Going up is an intra-articular, going down is a TKR type 2. In those situations, it's better to put the lateral plate and achieve a good stability on lateral side.
Okay. This question has been answered or not. In between, I was not there. Regarding the distal femur osteotomy that is commonly done for valgus deformity, does it have any ill effect on the patella tracking and Q angle? Should that to be taken under consideration for planning?
We answered that.
Answered. Okay, fine.
Once I had broken the lateral hinge, what I did was I just used 2 screws, one in the proximal fragment, one in the distal, and used a figure 8 wiring over them. So
Dr. Dinesh is doing routinely.
That is for close. Yeah, it's for close wedge. Close wedge.
He is adding that 2 screws and tension band.
I was doing with fixator and I broke the lateral hinge. So I did that.
That is a better, I think, better than plate, because in fixator it will not allow. Otherwise, if you put a plate, it will not allow the distraction. So if you are doing fixator assisted and broken the hinge, then tension band between 2 screws is much better. That only allows you the opening of wedge. Now, if another question, or we should further next.
Now,